Hello and welcome to our discussion on breast cancer. My name is Danielle Roman, the Manager for Clinical Pharmacy Services at Allegheny Health Network Cancer Institute in Pittsburgh, Pennsylvania. We have a big task in front of us with coverage of breast cancer. Nccn Guideline has more than 200 pages devoted to breast cancer management, and Asco has more than 20 guidelines that focus on this disease state. My hope today is that we'll be able to break down the data and talk about how to apply it to individual clinical scenarios. This presentation is part of the ASHP ACCP Oncology Pharmacy Specialty Review course, which is designed for pharmacists seeking to obtain recertification credit or update their knowledge and skills in preparation for board certification. This activity is designed to be interactive, with questions posed to you at several points. I will pause to allow time for you to consider how you would answer the question. You may wish to write down your answer and the correct response in your handout. There are no financial relationships relevant to this activity. Learning objectives are listed on the slide. We're going to be focusing on the treatment of patients with breast cancer. We'll also be discussing some key supportive care topics, including cardiotoxicity, supportive care for patients with bone mets, as well as survivorship. Please refer to the handout for additional information on breast cancer risk factors, prevention, and screening. Since breast cancer is such a big topic, we're going to focus on the fundamentals of treating breast cancer and in some of the areas of practice that have changed in the last year or so. We're going to break down our 2.5-hour time together into Part 1 and Part 2. In Part 1, we'll begin with a focus in the management of early stage and locally advanced breast cancer. This is stages 1 through 3. Here we'll talk about decision-making tools, and then we'll talk about therapies used in the neoadjuvant and adjuvant therapy areas, including endocrine therapy, chemotherapy, and targeted therapies. We'll wrap up Part 1 with a discussion of cardiotoxicity. The treatment of early-stage breast cancer often requires the use of multiple treatment modalities. Treatment approaches generally include treating the patient's local disease with surgery, radiation, or both, and systemic treatment with chemotherapy, endocrine therapies, targeted therapies such as HER2 targeting agents, or combinations. The selection of therapy depends on several prognostic and predictive factors, including the patient's tumor histology, their clinical and pathologic characteristics of the primary tumor, lymph node status, hormone receptor status, HER2 status, results of any genomic testing, patient's comorbid conditions, their age, menopausal status, and the patient's desire for treatment. I find one of the most challenging aspects of understanding breast cancer treatment in the early stage setting is understanding the sequencing of therapies, so I thought we'd start here with an overview. Most patients with early stage disease would begin treatment with surgery. If they're candidates for chemotherapy, this would follow surgery. For patients that may require endocrine therapy, this would follow their chemotherapy. It's important to note that chemotherapy and endocrine therapy would not be given concurrently. Endocrine therapy should follow chemotherapy in those patients that require both. For patients that require radiation, this would also come after chemotherapy. Radiation and endocrine therapy can be given concurrently or can be given sequentially. For those patients that need HER2 targeting agents, this is generally started at the time of adjuvant chemotherapy and is then continued for a total of 1 year. It's important to note that HER2 targeting agents can be given concurrently with patients' endocrine therapy and radiation therapy. In select patients, they may require neoadjuvant chemotherapy, and we'll discuss that in more detail in upcoming slides. We will be looking at various patient cases throughout the presentation to highlight key points in breast cancer management. We're going to start with a patient case, CH, with early stage breast cancer. CH is a 46-year-old postmenopausal Caucasian woman with a newly diagnosed left breast cancer. The primary tumor is 1.2 by 2.1 centimeters, negative lymph nodes. Pathology is invasive ductal carcinoma. It's found to be nuclear grade 1, meaning it's well differentiated. Estrogen receptor, or ER, 70%, meaning estrogen receptor is positive. progesterone receptor, or PR, is negative, and HER2 is negative. So this is a relatively small tumor without evidence of spread to lymph nodes or distant sites. This patient is considered to have early stage disease. Based on this information, what are our treatment options for CH? Surgical options include a lumpectomy or breast-conserving surgery, and just the area of the tumor is removed. This would depend on the patient's wishes and if there can be a good surgical outcome with this procedure. The second surgical option is a mastectomy or complete removal of breast tissue. Radiation therapy is required following a lumpectomy and can be considered post-mastectomy for patients with select risk factors, such as if the patient is lymph node positive or if surgical margins are close or positive. CH elects to have a lumpectomy with sentinel lymph node biopsy. Her tumor is 2.1 centimeters, negative axillary nodes. She has a stage 2A tumor, T2N0M0. CH has several good prognostic features, including being ER positive, HER2 negative, and a nuclear grade 1 or low grade tumor. Are there any other tests you would like to have in order to make decisions regarding her systemic adjuvant therapy? There are several prognostic tools which are important to discuss when talking about the management of early stage breast cancer. I'll briefly mention Adjuvant Online, which is a validated decision tool for the use of adjuvant systemic therapy based on the patient's clinical risk factors. I mention this because it is addressed in the Asco guideline. However, the website is currently unavailable. There are select gene expression assays which are routinely used in the management of early stage breast cancer. I've listed several of those options here. We'll focus on Oncotype DX and MammaPrint, but there are also several others, including the PAM50 test. We're now going to focus on the Oncotype DX genomic test. This is a diagnostic assay that quantifies the likelihood of breast cancer recurrence and assesses the benefit from chemotherapy for patients with newly diagnosed early-stage breast cancer. It uses RT-PCR to measure the expression of 21 genes, 16 of which are cancer-related and 5 reference genes. This test analyzes a specific patient's tumor sample to give a recurrence score, or RS, which shows the likelihood the cancer will recur following local treatment. This recurrence score can range anywhere from 0 to 100, and then can be used to group patients into a low, intermediate, or high risk for recurrence following local therapies. This test really helps to determine how aggressive a patient needs to be with adjuvant treatment. It's primarily used for patients with hormone receptor positive, lymph node negative disease. However, it can be considered in select patients that are hormone receptor positive with 1 to 3 positive lymph nodes. And this is based on the results of the RX-Ponder trial, which were recently reported at the San Antonio Breast Cancer Symposium. This test is currently not validated for patients with HER2 positive breast cancer. A landmark trial to support the use of Oncotype DX testing was the TAILOR-X trial. This was a very large study, prospective evaluation of the Oncotype DX testing to predict the benefit of adjuvant chemotherapy. This trial enrolled over 10,000 patients with hormone receptor positive, HER2 negative, lymph node negative disease, and it was designed to determine whether individuals that fit into an intermediate risk group benefited from the addition of chemotherapy to endocrine therapy, and also to confirm whether those in the low risk group had a good outcome with endocrine therapy alone. So this trial assigned patients into one of 3 groups based on their recurrence score. In the low risk group, this was a recurrence score of 0 to 10. Those patients received endocrine therapy alone. In the intermediate risk group, these were patients with a recurrence score of 11 to 25. And again, these were really the subject of this trial. They randomized these patients to either endocrine therapy alone or chemotherapy followed by endocrine therapy. Patients with a recurrence score of greater than 25 were put into the high risk group, and these patients received chemotherapy followed by endocrine therapy. So first, looking at the low-risk subset, these patients at 9 years of follow-up had a great response with just endocrine therapy alone. Nearly 94% were alive, and nearly 97% were free of distance recurrence. So this really confirmed the benefit of just endocrine therapy alone for those patients with a low recurrence score of 10 or less. In that intermediate risk subset, so these were patients again with a recurrence score of 11 to 25, At 9 years of follow-up, endocrine therapy was found to be non-inferior to the combination of chemotherapy and endocrine therapy for invasive disease-free survival. So this showed that chemotherapy really didn't add to outcomes for patients in this intermediate risk subset, and that endocrine therapy alone was enough to treat these patients. It's important to note that there was a benefit found for chemotherapy in a subgroup of patients, so younger patients, those with age less than or equal to 50 years old, and with a recurrence score that was on the higher end of that intermediate range, so those with a score of 16 to 25. And those patients did have a benefit with the addition of chemotherapy. The MINDAC trial looked at the use of the MammaPrint genomic test. This was another very large trial with almost 6,700 patients with hormone receptor positive early stage breast cancer that were randomized to chemotherapy in addition to their endocrine therapy versus no chemotherapy, which was just endocrine therapy alone, based on their risk assessment. The MammaPrint was used to assess genomic risk, and Adjuvant Online was used to assess the patient's clinical risk. This study focused on the 23.2% of participants with discordant results, so those that had a high clinical risk but a low genomic risk. And what was found at 8 years of follow-up was that the rate of survival without distant METs was not statistically significantly different between the groups. So it was 89.4% for those patients that did not receive chemotherapy versus 92% with chemotherapy. So this was only a 2.6% absolute improvement for those that received chemotherapy, really confirming that endocrine therapy alone is beneficial in this patient population. Overall survival was also not statistically significantly different between these two groups. Asco has published a guideline on the use of biomarkers, including gene expression assays, for decision-making in early-stage breast cancer. You can see there are a number of tests, including the Oncotype DX, EndoPredict, Breast Cancer Index, etc., that are recommended in patients that are hormone receptor positive, HER2 negative, lymph node negative disease, to guide their decision on whether or not they need adjuvant chemotherapy. Because the MINDAC trial did include patients with lymph node positive disease, this test can be recommended for patients that are hormone receptor positive, HER2 negative, that are either lymph node negative or positive for patients that are deemed to be at high clinical risk. Currently, no biomarker test is recommended for patients that either have HER2 positive disease or those patients that are deemed to be triple negative, meaning they are negative for estrogen receptor, progesterone receptor, and HER2. Asco guidelines break down recommendations based on recurrence score and age. For those patients aged greater than 50 with a low recurrence score of less than 26, endocrine therapy alone is recommended. 26 through 30, consideration for chemotherapy and endocrine therapy. And for those with a recurrence score of greater than 30, chemotherapy followed by endocrine therapy is recommended. For younger patients less than or equal to 50 years, a recurrence score of less than 16, endocrine therapy is recommended. 16 to 30, consideration for chemotherapy and endocrine therapy. And for those with a recurrence score of greater than 30, chemotherapy followed by endocrine therapy is recommended. CH's recurrence score is 11. What local, regional, or systemic adjuvant therapies, if any, would be appropriate for CH? We're going to use NCCN guidelines to look at appropriate management options for CH. NCCN breaks down management guidelines by looking at 4 major disease characteristics, including patients' hormone receptor status, their HER2 status, lymph node status, whether it's positive or negative, and the size of the primary tumor. We're going to look at this in increments. We're first going to start with a patient like CH that's hormone receptor positive, HER2 negative, and lymph node negative, so all being good prognostic factors. So we're going to first focus on the patient's primary tumor size. You'll notice here that most patients will be candidates for some form of systemic therapy. The exception here is the very top of this algorithm. Patients that have a primary tumor size of less than or equal to 0.5 centimeters, so very small tumors. There is a consideration for adjuvant endocrine therapy, but not a very well-studied patient population, and therefore it is not a strong recommendation, but just a consideration. Moving on, for patients with a primary tumor of greater than 0.5 centimeters. You'll notice here in the slide, based on the fact that this is hormone receptor positive disease, that adjuvant endocrine therapy is the mainstay of treatment for these patients. There is a strong consideration for the 21 gene assay, or the Oncotype DX testing that we discussed on previous slides. And then recommendations based on the recurrence score. So patients with a recurrence score of less than 26, the recommendation is for adjuvant endocrine therapy alone. For patients with an intermediate risk score of 26 to 30, the recommendation is for adjuvant endocrine therapy with a consideration of chemotherapy based on patient's desires and additional clinical risk factors. For patients with a higher recurrence score, so greater than or equal to 31, the recommendation is for adjuvant chemotherapy followed by adjuvant endocrine therapy. If patients do not have this 21 gene assay completed, the recommendation is for adjuvant endocrine therapy, but a consideration for the addition of chemotherapy based on, again, on the patient's desires, as well as any high-risk clinical features that may need to be considered here. The caveat to this, as we previously discussed based on the subset analysis of the Taylor X trial, for those patients, younger patients, so age less than or equal to 50, and a recurrence score in the 16 to 25 range, those patients may benefit from the addition of chemotherapy to endocrine therapy. We're now going to look at the management of early stage patients that are hormone receptor positive, HER2 positive, and lymph node negative. So the difference between this slide and the last slide is that these patients are HER2 positive. Again, we're going to start by looking at the patient's primary tumor size and breaking down management from there. We do know that HER2 positive disease generally has a poorer prognosis than in patients that are HER2 negative, and therefore you'll see that chemotherapy is a consideration for all patients that have HER2 positive disease, regardless of their tumor size. Starting with those patients, again, very small tumor size, primary tumor of less than or equal to 0.5 centimeters. If patients have no pathologic lymph nodes, then there is a consideration for adjuvant endocrine therapy, again, consideration of plus or minus chemotherapy. And if chemotherapy is administered, the recommendation is to also give a HER2 targeting agent with trastuzumab. For those patients, again, small primary tumors that have micrometastatic lymph node disease, the recommendation is for adjuvant endocrine therapy. You'll see that, so again, no consideration wording here, that adjuvant endocrine therapy plus or minus chemotherapy, so can be considered based, again, on patients' desires and clinical risk factors. And then HER2 targeting therapy with trastuzumab if chemo is administered. For patients that have a primary tumor of 0.6 to 1 centimeter, same recommendations as those with micrometastatic disease, being adjuvant endocrine therapy plus or minus chemotherapy, and then if chemo is given, trastuzumab should also be given. The patient population that is more well studied in this setting is those with a primary tumor of greater than 1 centimeter. And you can see here that this is where we don't have any kind of consideration wording, where adjuvant endocrine therapy is recommended in addition to chemotherapy and trastuzumab. So patients would get a combination of all three of these different systemic therapies. We're now going to continue to look at our early stage management options by looking at patients that are hormone receptor negative and lymph node negative. This slide contains both HER2 negative and HER2 positive recommendations. As you would expect, endocrine therapy is not listed as a management strategy, and this is because all of the patients on this slide have hormone receptor negative disease. You also don't see recommendations for genomic testing, and this is because patients with hormone receptor negative disease, this is currently not a recommended strategy, only recommended for those patients with hormone receptor positive disease. Again, breaking this down by primary tumor size. For patients with the smallest tumor size of less than or equal to 0.5 centimeters, no pathologic lymph nodes, and HER2 negative, so the very top part of this algorithm, no adjuvant systemic therapy is recommended. For patients with a primary tumor of 1 centimeter or less, so the entire top part of this algorithm, these patients would be considered for adjuvant chemotherapy. And if they're HER2 positive and chemotherapy is administered, trastuzumab should also be administered. For those patients in the bottom part of the algorithm with a primary tumor of greater than 1 centimeter, if they're HER2 negative, adjuvant chemotherapy alone is recommended. And for HER2 positive disease, trastuzumab would be added to adjuvant chemotherapy. And finally, we'll look at patients that have early stage lymph node positive disease. Now notice that NCCN guidelines do not break down treatment options based on the primary tumor size for patients with lymph node positive disease like we saw in the last several slides. So all patients with lymph node positive disease should be recommended to receive chemotherapy. If these patients are hormone receptor positive, you'll see that adjuvant endocrine therapy is also recommended. For patients that are HER2 positive, trastuzumab is recommended with or without pertuzumab. And we'll talk about these HER2 targeted strategies in upcoming slides. For those patients that are lymph node positive with less than 4 lymph nodes, hormone receptor positive and HER2 negative, you see here that there's a consideration for using the 21 gene assay or Oncotype DX testing to further direct therapy. We've arrived at our first audience response question. We're revisiting the case of patient CH, who's a postmenopausal woman with ER positive, PR negative, HER2 negative early stage breast cancer with an Oncotype recurrence score of 11. What is the most appropriate adjuvant therapy for CH? A, anastrozole, B, docetaxel and cyclophosphamide or TC, followed by anastrozole, C, tamoxifen, or D, docetaxel and cyclophosphamide, followed by tamoxifen. The correct answer here is A, anastrozole. Because of CH's low recurrence score, she does not require the addition of chemotherapy, and being postmenopausal and AI alone is an appropriate endocrine option. Options B and D would not be correct because this patient would not require the addition of chemotherapy with her low recurrence score. Option C with tamoxifen is not the most appropriate option for this patient because an AI is a preferred endocrine approach for a postmenopausal woman unless there is a contraindication to an AI. And we'll highlight where CH fits into our treatment algorithm. This patient had a tumor greater than 0.5 centimeters. She had the 21 gene assay testing conducted with a recurrence score that was less than 26, and therefore adjuvant endocrine therapy alone would be indicated. Here's our list of adjuvant therapy choices. We're going to refer to this as we move through the next section of slides. Our first adjuvant therapies that we'll discuss are endocrine therapies, including tamoxifen, aromatase inhibitors or AI, and ovarian ablation or suppression or OAS, which is done through the use of oophorectomy or luteinizing hormone-releasing hormone, LHRH agonists. The first important thing to know when determining an appropriate adjuvant endocrine option is the menopausal status of the patient. Is the patient pre or postmenopausal? I would refer you to NCCN guidelines for a detailed definition of menopausal status. Most of our options here are targeting the source of estrogen in these two patient populations. The ovaries are the greatest source of estrogen for premenopausal women, whereas in postmenopausal women, the ovary is no longer a source of estrogen. Here, estrogen is mainly produced in peripheral tissues. An exception to this is tamoxifen, which is an antagonist at the level of the estrogen receptor on breast cancer cells. So you can see here that tamoxifen is used across pre- and postmenopausal patient populations. So here's a high-level overview of options for women based on their menopausal status. So if we first look at premenopausal patients, so tamoxifen is an option and was historically the only option for premenopausal women. Results of recent trials have expanded options here to include ovarian ablation or suppression, or OAS, in combination with tamoxifen, or OAS in combination with an aromatase inhibitor, AI. Notice that ovarian ablation or suppression alone is not recommended. In postmenopausal women, there's options for an AI, options for sequential regimens of an AI and tamoxifen, or tamoxifen alone. And just to note here, tamoxifen alone is really only considered to be an option for women that can't tolerate or refuse therapy with an aromatase inhibitor. Important to note, in patients receiving both endocrine therapy as well as chemotherapy, chemotherapy should be given first, and this would be followed sequentially by endocrine therapy. We'll dive into premenopausal endocrine options. Options here include tamoxifen for an initial 5 years, tamoxifen plus OAS for 5 years, or an AI plus OAS for 5 years. The addition of OAS is considered a Category 1 recommendation for women at higher risk of recurrence. So this includes women who are younger age, have a higher grade tumor, have lymph node involvement, or potentially those patients where you're considering chemotherapy in addition to endocrine therapy. If we look at women that receive tamoxifen alone for the first 5 years or tamoxifen plus OAS for the first 5 years, menopausal status should be assessed at the end of that 5-year mark. For women who remain premenopausal at that time, the consideration is for an additional 5 years of tamoxifen to complete a total of 10 years of endocrine therapy, or no further therapy. For patients who are postmenopausal at the end of this initial 5 years of therapy, recommendation is to consider tamoxifen for an additional 5 years to complete 10 years of therapy, or at this point, a patient could be switched to an AI for an additional 5 years to complete 10 years of endocrine therapy. For those patients that received an initial AI plus OAS for 5 years, they could go on to receive no further therapy, or if these patients are postmenopausal at the end of their initial 5 years, they could be switched over to an AI to complete an additional 3 to 5 years of treatment. We'll now look at adjuvant endocrine options for postmenopausal women. Regimens that include an AI are preferred, and all 3 AIs, that's anastrozole, letrozole, and exemestane, are considered to be therapeutically equivalent. You'll notice here that there are a number of options. One option is an aromatase inhibitor for anywhere from 5 to 10 years of treatment. Of note, Asco does recommend a total of 10 years for patients that are lymph node positive. There are a number of sequential regimens recommended, so either starting with tamoxifen and completing with an AI, or starting with an AI and completing with tamoxifen for varied durations of time. If a patient has a contraindication to an AI, then tamoxifen can be considered from anywhere from 5 to 10 years of treatment. The optimal duration of an AI in the adjuvant setting really has not been determined, and that's why you see here that there are a range of anywhere from a total of 5 to 10 years recommended. It's well known that patients should receive at least 5 years of adjuvant endocrine therapy. So we'll talk about some of the data looking at extended durations of therapy. So first, looking at more than 5 years of adjuvant tamoxifen, the data here is based on 2 large trials, the Atlas and the Atom trial. The historical standard was always 5 years of endocrine therapy. So in the Atlas trial, they looked at 5 compared to 10 years of adjuvant tamoxifen therapy and found that 10 years reduced the risk of recurrence and mortality versus 5 years of therapy. However, longer durations of therapy with tamoxifen also increased toxicity. This included PE as well as endometrial cancer. In the Atom trial, 10 years of tamoxifen was also compared to 5 years and did find a reduced risk of recurrence, but not a reduced risk of mortality. And also here, they found that the longer durations of tamoxifen therapy were also associated with increased toxicity, including endometrial cancer and endometrial cancer-related deaths. There was another large randomized clinical trial, the NSABP B14 that showed no benefit of tamoxifen beyond 5 years. This is why we see NCCN guidelines state to consider an additional 5 years of tamoxifen after the initial 5 years. There is evidence to support extending adjuvant AI therapy beyond 5 years. This is coming from the MA17R trial, which randomized 1,900 patients who had received 4.5 to 6 years of prior AI therapy. More than half of patients had also received prior tamoxifen therapy. And it randomized these patients to an additional 5 years of AI therapy with letrozole or placebo. There was a statistically significant improvement in 5-year disease-free survival with the addition of letrozole compared to placebo. There was also a reduced incidence of contralateral breast cancer, but there was no difference in overall survival in this trial. This is why NCCN guidelines state to consider an additional 3 to 5 years of an AI after the initial 5 years for up to 10 years total therapy. Asco guidelines also recommend an AI for 10 years and limited to those patients with lymph node positive disease. We'll briefly discuss some of the evidence behind combined endocrine therapy approaches for premenopausal women. Remembering back to previous slide, the combined endocrine approaches were OAS in combination with an AI or OAS in combination with tamoxifen. To support this data, the SOFT and TREX trials were combined and analyzed. OAS in these trials was either triptorelin, which is an LHRH agonist, oophorectomy, or ovarian radiation, all which were used to shut down ovarian function. OAS was either given in combination with tamoxifen or an AI exemestane for 5 years. The 8-year disease-free survival was very good in both arms, but was statistically significantly better in those patients that received exemestane plus OAS. The toxicities in each arm were as expected for each agent. There was higher incidence of toxicity in those patients that received combination therapy compared to those patients that received single-agent tamoxifen. NCCN guidelines recommends to consider these combined strategies, OAS plus an AI or OAS plus tamoxifen, for patients that are premenopausal and at higher risk for breast cancer recurrence. This includes patients with younger age, higher grade tumor, and those with lymph node involvement. Here are some key takeaways from the Asco guideline for adjuvant endocrine therapy. Endocrine therapy is only recommended for patients that express greater than or equal to 1% ER or PR positivity. Patients who are pre or perimenopausal at the time of breast cancer diagnosis could be treated with options including tamoxifen as a single agent, OAS plus tamoxifen, or OAS plus an AI, the same options that we discussed for NCCN. Asco considers the OAS combination for those with stage 2 or 3 disease that receive adjuvant chemotherapy, and states that stage 1 disease not receiving chemotherapy should not be offered the combinations with OAS. They also state that there is no data for OAS combination beyond 5 years based on the SOFT and TEX trial results. Asco guidelines state that most postmenopausal women should consider taking an AI to lower risk of recurrence, but tamoxifen can be considered for those that have a contraindication to using an AI. YC is a 37-year-old premenopausal African-American woman who presents with newly diagnosed right breast cancer. She is a 1.3 by 1.3 centimeter tumor, stage 1A, lymph node negative. It's invasive ductal carcinoma, which is moderately differentiated. ER/PR 0%. HER2 is 2+ on IHC, but FISH negative, and therefore overall HER2 negative. This patient is deemed to have triple negative disease. Her Ki67, a marker of cell proliferation, is 50%, which is high. She has a germline BRCA2 mutation, no other comorbidities, and is treated with a modified radical mastectomy. ARS question number 2. According to NCCN guidelines, which of the following chemotherapy regimens would be most appropriate for YC? Is it A, combination of cyclophosphamide, methotrexate, and fluorouracil, known as CMF? B, carboplatin? C, dose-dense docetaxel plus cyclophosphamide, or AC, followed by paclitaxel? Or is it D, olaparib? The correct answer is C, dose dense AC followed by paclitaxel. Answer A is incorrect because CMF is only recommended for those patients that cannot tolerate other preferred regimens. And this patient would likely be able to tolerate because she's young with no comorbidities. Answers B and D are incorrect because these regimens are not recommended in the adjuvant setting. YC has lymph node negative, hormone receptor negative, HER2 negative disease. Additional chemotherapy regimens beyond dose-dense AC followed by paclitaxel are listed in the handout. This patient would not be a candidate for adjuvant radiation therapy because she received a mastectomy. She has no lymph nodes and her tumor was less than 5 centimeters. She would be followed closely for the rest of her life for any evidence of recurrence or new primary breast cancers. I think it helps to put this case into perspective if we look at how she fits into those initial algorithms that we discussed. So going back to our algorithm for patients with lymph node negative, hormone receptor negative disease, and we know that this patient had a tumor greater than 1 centimeter and is HER2 negative, so she fits into the category of patients that should receive adjuvant chemotherapy alone. Returning to our list of adjuvant therapy choices, we're going to move down to our chemotherapy options, which generally include anthracycline-containing and taxane-containing regimens. There's an Asco guideline addressing the role of adjuvant systemic therapy for early-stage breast cancer. Asco states to consider the use of adjuvant chemo for the following tumor characteristics: lymph node positive, ER-negative tumors that are greater than 0.5 centimeters, HER2 positive, high-risk lymph node negative tumors greater than 0.5 centimeters that have one additional high-risk feature, including grade 3, triple negative, lymphovascular invasion based on the Oncotype DX score, or HER2 positive. They also note that adjuvant online can be used here. However, it's important to note that this tool is currently not available. Options for adjuvant chemotherapy regimens are listed on this slide. The optimum regimen has not been determined. There are many evidence-based regimens available. All adjuvant regimens listed in NCCN Guidelines have been evaluated in phase 3 clinical trials. NCCN does notate preferred regimens based on efficacy, safety, and cost, and those preferred regimens are notated on this slide with the superscript A. That includes dose-dense AC, so that's AC on an every 2-week basis, followed by paclitaxel, either paclitaxel weekly or every 2 weeks. And also the regimen TC, which is docetaxel and cyclophosphamide. So either of these options are considered to be preferred regimens by NCCN. Other regimens, although not preferred, but are recommended, include TAC, which is docetaxel, doxorubicin, cyclophosphamide, AC in the traditional Q3 week schedule followed by docetaxel, or AC every 3 weeks followed by weekly paclitaxel. Of note, dose-dense AC is preferred to conventional Q3 week AC. This was based on a trial that compared the two, each followed by paclitaxel, that found a reduction in the risk of recurrence as well as a reduction in the risk of death for the dose-dense regimens. Other options for regimens that are non-taxane containing are dose-dense AC or EC given every 3 weeks. And then for those patients that may not be able to tolerate an anthracycline or a taxane, we have our option for CMF, which is cyclophosphamide, methotrexate, and fluorouracil. ASCO guidelines for adjuvant chemotherapy identify an anthracycline and taxane-containing regimen as being an optimal selection for patients. They also notate the optimal dose of anthracycline for patients that are not receiving a taxane, and those limits are listed on the slide here. In summary, anthracyclines and taxane-containing regimens are the standard of care for patients who receive adjuvant chemotherapy. In particular, for patients with higher risk features, such as those with larger tumors, lymph node positive status, triple negative, the inclusion of both anthracyclines and taxanes may be recommended. However, there are other appropriate regimens, such as TC, which is identified as a preferred regimen, by NCCN Guidelines, so TC being a taxane-containing regimen but does not include an anthracycline. Other regimens, such as CMF, may be appropriate for subgroups of patients that may not be able to tolerate an anthracycline and/or taxane-containing regimen. In particular, risk and benefit analysis is important for every patient, and looking at pre-existing comorbidities and patients' desires for therapy in order to determine the most appropriate regimen for that patient. The handout contains additional details of the adjuvant chemotherapy regimens, including dosing and administration. We're going to revisit our sequencing slide as we transition into some discussion of patients with locally advanced breast cancers. Much of what we discussed in the early stage also applies for those patients with locally advanced disease. Now, generally, all of the same treatment modalities are included here. Surgery, adjuvant therapies, including the potential for chemotherapy, endocrine therapy for those patients that are hormone receptor positive, and HER2 targeting agents for those patients that are HER2 positive. Also, radiation is generally considered for these patients. The major difference to highlight is the use of neoadjuvant therapy, and this is much more common in patients with locally advanced disease. Giving neoadjuvant therapy before surgery helps to improve surgical outcomes, as well as helps to direct adjuvant therapy options following surgery. We'll briefly cover some principles of neoadjuvant therapy. The chemotherapy regimen options that we discussed in the adjuvant setting are the same regimens that should be considered in the neoadjuvant setting. In some limited situations, endocrine therapy alone may be considered for neoadjuvant therapy for those patients with hormone receptor positive disease, but this is not a common occurrence. For those patients receiving neoadjuvant therapy that have HER2 positive tumors, HER2 targeted therapy such as trastuzumab should be included as part of their neoadjuvant regimen. Also, generally all chemotherapy is given preoperatively. Additional adjuvant systemic therapy may be indicated based on the patient's surgical pathology. Candidates for neoadjuvant therapy could include patients that are initially deemed inoperable and patients that are initially deemed operable. For those patients who are inoperable, the goal of neoadjuvant therapy is to try to convert them to operable. Generally, these patients that are inoperable initially include patients with inflammatory breast cancers, those with bulky N2 axillary nodes, those with N3 disease, or large T4 tumors. Patients that are initially deemed operable may also be candidates for neoadjuvant therapy in order to help guide adjuvant therapy choices, as well as to help improve surgical outcomes. For those patients with HER2 positive disease or triple negative disease that have a T primary tumor greater than or equal to 2 or N greater than or equal to 1 may be candidates for neoadjuvant therapy. Those with large primary tumors relative to their breast size in order to improve surgical outcomes with the use of breast conservation therapy. And also patients with node positive disease who are likely to become node negative with use of preoperative systemic therapy, again, in order to improve surgical outcomes. Patient VT has locally advanced breast cancer. She is a 58-year-old postmenopausal Caucasian woman who is diagnosed with the stage 3A, this being a T2N2M0 invasive ductal carcinoma. She has PR negative, HER2 negative disease, so this would be triple negative. This patient is treated with neoadjuvant AC in a dose-dense fashion every 2 weeks for 4 cycles, followed by weekly paclitaxel for 12 cycles. Following this neoadjuvant treatment, she undergoes breast-conserving surgery, and at the time of surgery, she is found to have residual disease in the breast. Audience response question number 3. In addition to radiation, which adjuvant treatment is most appropriate for VT? A. Adatrastuzumab emtansine. B. Docetaxel and cyclophosphamide, or TC. C. Paclitaxel plus carboplatin. Or D. Capecitabine. The most appropriate answer here is D. Capecitabine, because this patient has triple negative disease and residual disease following neoadjuvant treatment. Option A is incorrect because this patient does not have HER2-positive disease. Option B is incorrect because this patient has received her taxane-containing regimen in the neoadjuvant setting. And option C is incorrect because paclitaxel and carboplatin is not a recommended approach for this patient. Capecitabine has a well-established role in the treatment of metastatic breast cancer, but up until recently did not have much of a role in the early stage setting. The Createx Trial was a large trial of over 900 patients. It was an open-label phase 3 trial, and the goal here was to assess the role of adjuvant chemotherapy for patients that had residual disease following neoadjuvant chemotherapy. The historical standard for these patients would have been observation, but we know these patients have a high risk for recurrence. This trial randomized patients to adjuvant capecitabine on days 1 through 14 every 21 days for 6 to 8 cycles, or to the placebo control arm. The median age of patients in the trial was 48 years old. Primary endpoint was disease-free survival. At 5 years of follow-up, the disease-free survival was 74% versus 67.6% in favor of capecitabine. Overall survival was also longer in the capecitabine group. Most impressive was the subgroup of patients with triple-negative disease. Disease-free survival and overall survival were improved with the capecitabine groups, with a hazard ratio of 0.58 for disease-free survival and hazard ratio of 0.52 for overall survival. It's important to note that capecitabine was associated with significant toxicity for patients. Based on the impressive results in the triple-negative population and knowing this significant adverse effects, NCCN and Asco guidelines recommend to consider adjuvant capecitabine for patients that have residual disease and are triple negative. Also, it's important to note that the dose of capecitabine that was used in the trial was associated with higher toxicity in patients that were 65 and older. So that was the dose of 1,250 milligram per meter squared BID. The recommendation is to consider using a lower dose, such as 1,000 milligram per meter squared, in the elderly patient population. We'll move on to patient case HF. It's a 60-year-old female with minimal comorbidities. She's newly diagnosed with a stage 3B disease. This was a T4N2M0 left breast cancer. She's ER 70%, PR 0%, and HER2 positive with an IHC of 3+. The plan for this patient is lumpectomy followed by radiation. Audience response question number 4. What would be the most appropriate neoadjuvant regimen for HF? She's postmenopausal, stage 3B, ER positive, PR negative, and HER2 positive. A, AC plus trastuzumab for 4 cycles. B, docetaxel, trastuzumab, and pertuzumab for 6 cycles. C, TCH plus pertuzumab for 6 cycles, also known as TCHP. Or D, AC for 4 cycles, followed by paclitaxel weekly for 12 cycles. The correct answer here is C, TCH plus pertuzumab for 6 cycles. This regimen, also known as TCHP, is a recommended neoadjuvant approach for patients with HER2 positive disease. Answer A is incorrect because AC and trastuzumab should not be given at the same time. The combination of HER2 targeting agents plus an anthracycline should not be given at the same time due to increases in the risk of cardiotoxicity with both of those drugs together. Option B is incorrect because this regimen is not currently recommended in the neoadjuvant setting, would only be recommended in the metastatic setting. And option D is incorrect because this option does not contain any HER2 targeted therapies, which would be appropriate for our patient HF because of her HER2 positive disease. To summarize our patient HF, she has stage 3B disease, lymph node positive, hormone receptor positive, and HER2 positive. A trastuzumab-based chemotherapy regimen with or without pertuzumab would be preferred, as is the case with our regimen TCHP that we recommended for patient HF in the neoadjuvant setting. Following completion of her neoadjuvant TCHP, HF undergoes a lumpectomy. She's found to have residual disease at the time of surgery. Following surgery, this patient would be a candidate for radiation therapy. She's also a candidate for adjuvant HER2-targeted therapies. She would also begin an endocrine therapy regimen with an AI following the completion of her neoadjuvant chemotherapy and surgery. Audience response question number 5. Which of the following is the most appropriate adjuvant HER2-targeted therapies for HF? Is it A, trastuzumab, B, adatrastuzumab emtansine, C, trastuzumab plus pertuzumab, or D, neratinib? The correct answer here is B, adatrastuzumab emtansine, and that is based on the results of the Catherine trial that we'll cover in upcoming slides. Answer A is incorrect because trastuzumab as a single agent would be most appropriate for those patients that did not have residual disease at the time of surgery. Answer C is incorrect because the combination of trastuzumab and pertuzumab would also be a potential recommended strategy for those patients that did not have residual disease at the time of surgery. And answer D is incorrect because neratinib is currently only approved for patients in the extended adjuvant therapy. This is after patients had completed a course, at least 1 year of HER2-targeted therapy. We'll now move into discussion of HER2-targeted therapies in the neoadjuvant and adjuvant setting, including trastuzumab, pertuzumab, neratinib, and adatrastuzumab emtansine. Our options for HER2 targeting therapy in the neoadjuvant or adjuvant setting include trastuzumab, pertuzumab, the combination of trastuzumab, pertuzumab, and hyaluronidase for sub-Q administration, our antibody drug conjugate adatrastuzumab emtansine, or our TKI neratinib. Of note, trastuzumab, pertuzumab, and the combination of the two may be administered in the neoadjuvant and or adjuvant settings. Adatrastuzumab emtansine and neratinib are only recommended in the adjuvant settings. The use of HER2-targeted therapies in the neoadjuvant and adjuvant settings with the use of such drugs as trastuzumab and pertuzumab is well established for those patients with HER2-positive disease. There's been a significant decrease in the risk of recurrence and an overall survival benefit with the use of these agents. Trastuzumab is well studied for patients with HER2-positive disease and tumor size of greater than 1 centimeter. And therefore it's recommended for all patients that meet this criteria. Trastuzumab should be considered for those patients with HER2-positive disease that have tumors less than 1 centimeter, but has not been well studied in this patient population. The addition of pertuzumab to trastuzumab should be considered for those patients with HER2-positive disease, tumor size of greater than 2 centimeters, or those with lymph node-positive disease. It's preferential to administer the HER2-targeted agents in combination with chemotherapy regimens, whether that's starting in the neoadjuvant or adjuvant setting. The exception to this is in use with anthracycline. Due to additive cardiotoxic effects, it is not recommended to administer HER2 targeting agents concurrently with anthracyclines. Trastuzumab with or without pertuzumab is currently recommended for a total of 1 year as the standard of care. This includes both therapy in the neoadjuvant as well as adjuvant settings. Important to note, monotherapy with pertuzumab is not effective. Therefore, if pertuzumab is going to be used, it must be in combination with trastuzumab. There were 2 main trials that define the role of pertuzumab in the neoadjuvant setting. The Neosphere Trial was a randomized, open-label, phase 2 study of patients with HER2-positive disease, either early stage, locally advanced, or inflammatory, with patients that had a primary tumor of greater than 2 centimeters. This included a little over 400 patients that were assigned to one of 4 neoadjuvant regimens. These neoadjuvant regimens were various combinations of docetaxel, trastuzumab, and pertuzumab. After surgery, eligible patients went on to receive adjuvant FEC, and patients also received a total of 1 year of trastuzumab therapy. The primary endpoint was pathologic complete response, or PCR, which is defined as the absence of cancer cells at the time of surgery. There was a statistically significant improvement in PCR rates with the addition of neoadjuvant pertuzumab to trastuzumab and docetaxel. There was a higher incidence of diarrhea and skin rash with the addition of pertuzumab, although all treatment arms were fairly well tolerated. The second trial, Trifina, was a randomized open-label phase 2 study that was really designed to look at tolerability and the cardiac safety of the combination of trastuzumab and pertuzumab. It was looked at in combination with anthracycline, as well as anthracycline-free regimens, such as the one previously discussed, TCHP. The primary endpoint was cardiac safety, and it was shown to have a low incidence of cardiac complications. Although not designed to compare between these arms from an efficacy perspective, the majority of patients on this trial did achieve a PCR. And therefore, results were encouraging with all of these combinations. I'd like to briefly mention a newer product, which is the combination of pertuzumab, trastuzumab, and hyaluronidase, brand name Phesgo. This was approved by the FDA in 2020. It's approved for all of the same indications as the IV combination of pertuzumab and trastuzumab. So this could be with or without chemotherapy in the neoadjuvant, adjuvant, or metastatic settings. The recommended dose is listed here. You'll notice that there's an initial as well as maintenance dosing. The initial dose is given as a subcutaneous injection in the thigh over 8 minutes, and the maintenance is the same, but given over a 5-minute duration. And this product is given every 3 weeks. Toxicities are the same as what you would expect with a trastuzumab and pertuzumab combination. There is a black box warning for cardiac toxicity, as well as pulmonary toxicity, which could include interstitial pneumonitis, as well as acute respiratory distress syndrome. Toxicities also include injection site reactions, as would be expected for a patient receiving a subcutaneous injection. I'd now like to focus on those patients with HER2-positive disease and talk about the role of residual disease in determining further therapy. Guidelines state that for patients that have no residual disease following their neoadjuvant therapy, or for patients that don't receive any neoadjuvant treatment, the combination of trastuzumab with or without pertuzumab is recommended in the adjuvant setting for up to 1 year of HER2-directed therapy. For those patients that do have residual disease following neoadjuvant therapy, it is recommended that patients go on to receive adotrastuzumab emtansine times 14 cycles in the adjuvant setting. It's noted that if patients need to discontinue the adotrastuzumab emtansine for toxicity, that it would be recommended to administer the combination of trastuzumab with or without pertuzumab to complete up to 1 year of HER2-directed therapy. These recommendations are based on the results of the Catherine trial. This was a randomized open-label phase 3 trial with nearly 1,500 patients. These patients had HER2-positive non-metastatic disease. They have received neoadjuvant taxane-based chemotherapy plus HER2 targeting agents in the neoadjuvant setting. And these patients had pathologic residual disease in their surgical specimen at the time of surgery. And so this was a high-risk patient population that we knew had a higher risk for recurrence that traditionally would have gone on to receive single-agent trastuzumab as standard of care, residual disease or not. So this trial randomized these higher-risk patients with residual disease to adotrastuzumab emtansine every 21 days for 14 cycles, or standard of care trastuzumab single agent every 21 days for 14 cycles. The primary endpoint was invasive disease-free survival. The interim analysis results of this trial were very impressive and really practice-changing. The risk of recurrence or invasive breast cancer or death was 50% lower with the use of adjuvant adotrastuzumab emtansine compared to trastuzumab in these patients with residual disease. You can see here the 3-year invasive disease-free survival, 88% versus 77%, with a hazard ratio of 0.5. There's also improvement in distant recurrence and overall survival, although overall survival results are immature at this time. And notably, there was a consistent benefit for adagrasib emtansine across all subgroups studied. The Affinity Trial examined the role of adjuvant pertuzumab. This is a large trial of over 4,800 patients with lymph node positive or high-risk lymph node negative operable breast cancer. These patients did not receive any neoadjuvant therapy. They went straight to surgery and then were randomized to chemotherapy for 3 to 6 cycles, plus trastuzumab plus pertuzumab for 1 year, or standard of care chemotherapy for 3 to 6 cycles, plus trastuzumab and placebo for 1 year. The primary endpoint was rate of invasive disease-free survival. Most of these patients had lymph node positive disease, and most patients were hormone receptor positive. If we look at the performance of pertuzumab in the adjuvant setting, the 3-year rate of invasive disease-free survival was 94.1% in the pertuzumab-containing arm versus 93.2% in the placebo arm. So this was just a modest 0.9% absolute benefit, so less than 1% absolute benefit for the addition of pertuzumab in this patient population. Specifically looking at those subgroup of patients with lymph node positive disease, the 3-year invasive disease-free survival rate was 92 versus 90.2, that was statistically significant, but was not significant for the subgroup of patients with lymph node negative disease. At 6 years of follow-up, there was no statistically significant difference in overall survival with the addition of pertuzumab. So it was really found that the improvement for these patients, though modest, was more substantial in the lymph node positive population. And of note, pertuzumab has been associated with more diarrhea. Based on these results, the NCCN and Asco guidelines recommend to consider the addition of pertuzumab in the adjuvant setting for patients with lymph node positive disease. I'd like to highlight one additional trial in the early stage locally advanced setting, and that's the Extanet Trial. This was looking at extending adjuvant therapy beyond the 1 year of HER2-directed therapy. This trial included patients with HER2-positive operable breast cancer who had received prior adjuvant trastuzumab and chemotherapy. And this trial was initiated at the time that pertuzumab was not a standard of care. These patients completed trastuzumab less than or equal to 1 year prior to entry in the study, and patients were lymph node positive or had not received a PCR after their neoadjuvant therapy. So following their chemotherapy and their 1 year total of HER2-directed therapy, they were randomized to additional HER2-directed therapy with neratinib for 1 year or placebo for 1 year. The primary endpoint was invasive disease-free survival. It was found that there were fewer disease-free survival events in the neratinib group with a hazard ratio of 0.73. The 5-year disease-free survival was 90.29 in the neratinib group versus 87.7% in the placebo group. And interestingly, this benefit was greater in the subgroup of patients that had hormone receptor positive disease. That was not an expected result of the study. But based on that, both NCCN and Asco recommend to consider the use of neratinib in patients at higher risk for recurrence, and preferentially recommending this in patients with hormone receptor positive and lymph node positive disease. Notably, there was no overall survival benefit in this study. Diarrhea is an important toxicity to discuss with neratinib, a tyrosine kinase inhibitor. 95% of patients on the Extanet trial developed diarrhea, and this was 40% a grade 3, so a number of patients that had high-grade diarrhea that significantly has the ability to affect quality of life. The median onset to diarrhea was 8 days, and the median duration of grade 3 or higher diarrhea was 5 days. Based on these high rates of diarrhea, there is an anti-diarrheal prophylaxis regimen that is recommended with the use of this agent. And this is recommended with the first 2 cycles of treatment. So for a total of the first 56 days of treatment, loperamide is recommended on weeks 1 and 2 at a dose of 4 milligrams TID scheduled. Weeks 3 and 8, this can be decreased to 4 milligrams BID. And then weeks 9 through 52, loperamide 4 milligrams can be recommended as needed for patients, not to exceed 16 milligrams a day. The recently published results of the control trial also suggest that the addition of budesonide or cholestyramine to this loperamide maintenance strategy may be beneficial. Or authors also recommend a strategy of dose escalation with neratinib that has been shown to reduce the incidence of severe diarrhea. We're back to our list of adjuvant therapy choices, and we're going to wrap up our discussion of adjuvant therapy with the role of bisphosphonates. The adjuvant bisphosphonates for the treatment of early stage breast cancer, I want to point out that we're not talking about patients that have bone mets. We're not talking about patients specifically with osteopenia or osteoporosis, although they may have that. But when we look at all-comer early stage breast cancer, the Early Breast Cancer Trialist Collaborative Group did a meta-analysis of various trials that looked at the addition of bisphosphonate therapy to patients' early stage breast cancer regimen. And what they found was that the bone recurrence rate, distant recurrence, and breast cancer mortality were all significantly improved with the addition of bisphosphonates to systemic therapies. And this was most notable in patients that were postmenopausal. Based on this, Asco, in their joint recommendation with Cancer Care Ontario and Nccn Guidelines, recommend to consider the use of adjuvant bisphosphonates for postmenopausal women who are candidates for adjuvant systemic therapy. So this would be given in addition to other systemic therapies such as endocrine therapy, chemotherapy, or HER2-directed therapy. This also could include premenopausal women who have become postmenopausal because of ovarian function suppression, such as with the use of LHRH agonists. Options here for bisphosphonate therapy include zoledronic acid, 4 milligrams every 6 months for 3 to 5 years, or cladronate, which is a PO option given for 2 to 3 years. And of note, cladronate is not currently available in the US. We'll now move into our first supportive care topic with a discussion of cardiotoxicity with breast cancer regimens. Audience response question number 6. HF is planned to receive TCHP for 6 cycles followed by surgery for her diagnosis of HER2-positive stage 3B breast cancer. According to pertuzumab's prescribing information, what is the appropriate frequency of monitoring her LVEF during neoadjuvant therapy following her baseline assessment? A, every 12 weeks, B, every 6 months, C, every 6 weeks, or D, every 2 months? The correct answer here is answer A, every 12 weeks. The prescribing information recommends monitoring LVEF with an echo or MUGA scan every 12 weeks. So this ends up being once during the patient's neoadjuvant treatment. So following their baseline assessment, 12 weeks in would put them right around cycle 4 of TCHP for LVEF assessment. Our patient HF would be monitored for signs and symptoms of heart failure during her therapy and would undergo regular assessments of LVEF with an echo or MUGA, so baseline every 3 weeks during her TCHP regimen, and then LVEF would be monitored at regular intervals every 3 months during her adjuvant treatment with trastuzumab emtansine. Audience response question number 7. What is the most appropriate recommendation if HF's left ventricular ejection fraction decreased from a baseline of 55% to 40% via MUGA scan prior to cycle 6 of TCHP? The institutional lower limit of normal here is 45%. A, continue trastuzumab and pertuzumab. B, hold trastuzumab and pertuzumab. C, restart trastuzumab but discontinue pertuzumab, or D, restart pertuzumab but discontinue trastuzumab. The correct answer here is B, hold trastuzumab and pertuzumab. This patient's left ventricular ejection fraction has decreased from her baseline of 55% to now 40% after 5 cycles of TCHP. This is an absolute decrease of 15 percentage points. The prescribing information recommends to hold both pertuzumab and trastuzumab for those patients with an ejection fraction of less than 50% and with a fall of greater than or equal to 10 percentage points from their pretreatment or baseline value. HF meets this criteria. She should be referred for heart failure management and close monitoring of her ejection fraction. Upon improvement of her ejection fraction, her pertuzumab and trastuzumab can be restarted. Trastuzumab administration can result in the development of ventricular dysfunction and congestive heart failure. Studies have differed in the rates of cardiotoxicity, but it's generally less than 4%. Acceptable rates of this cardiotoxicity in studies may be due to rigorous monitoring that was done in study protocols. It's important to appropriately select patients by doing baseline assessment of risks for cardiac dysfunction, including history and physical exam. Ejection fraction by MUGA scan or echo is recommended at various time points. This includes prior to the initiation of therapy or baseline, every 3 months during and on completion of trastuzumab, and it's recommended every 6 months for at least 2 years following the completion of trastuzumab. Trastuzumab should be held for at least 4 weeks for patients that meet the following criteria. For patients that have a greater than or equal to 16% absolute decrease in LVEF from their pre-treatment values, or an LVEF that is below the institutional limits of normal and has been a greater than or equal to 10% absolute decrease in value from their pretreatment value. Therapy with trastuzumab may be resumed if the ejection fraction returns to normal limits within 4 to 8 weeks, and if the absolute decrease from baseline is less than or equal to 15 percentage points. When we consider cardiac monitoring for patients receiving pertuzumab, it's important to remember that these patients will also be receiving trastuzumab. As previously discussed, patients should have a baseline assessment for risk of cardiac dysfunction, including history and physical exam. The ejection fraction should be monitored by MUGA scan or echo prior to the initiation of therapy and every 12 weeks during treatment. Recommendations to hold therapy are based on the setting in which the drug is being used. For those patients with metastatic breast cancer, it's recommended to hold pertuzumab and trastuzumab for at least 3 weeks if the LVEF is less than 40%, or for patients with an LVEF of 40 to 45% and a fall of greater than or equal to 10 percentage points below their pretreatment value. In the setting of neoadjuvant or adjuvant therapy, it's recommended to hold pertuzumab and trastuzumab for at least 3 weeks for an LVEF of less than 50% with a fall of greater than or equal to 10 percentage points from their pretreatment value. When we consider cardiac toxicity in general, there's usually 2 types that are considered. One of those types, so type 2, is what we've discussed with HER2 targeting agents, and this is typically reversible cardiac toxicity. Type 1 cardiac toxicity is generally associated with the anthracycline drug class, is typically dose-related, and may be irreversible. Anthracycline cardiac toxicity is a complication of not just breast cancer, but in any cancer where we're using anthracycline therapy. It can present as acute, chronic, or late onset. Acute cardiotoxicity usually occurs immediately after a single dose. It's typically not related to cumulative dose, may involve abnormal EKG findings, and is considered to be uncommon or a transient complication. Chronic cardiotoxicity with anthracyclines onset is usually within a year of receiving the anthracycline therapy. It's rapid onset. It's more common than the acute toxicity and can be life-threatening, and is typically related to cumulative dose. Late onset cardiotoxicity may develop several years or even decades after patients have received anthracyclines. This typically manifests as ventricular dysfunction, CHF, arrhythmias, and various other cardiac abnormalities. This is usually more common in childhood cancer survivors. So risk factors for cardiotoxicity with anthracyclines are listed here for you. So notably, patients that are older, so greater than the age of 65, have cardiac risk factors already, such as hypertension, dyslipidemia, family history of cardiac myopathy, history of other cardiovascular comorbidities, smokers, obese patients, those with a low normal LVEF at baseline. And then important for us as pharmacists to recognize that this cardiotoxicity with anthracyclines is related to cumulative lifetime dosing. So the higher the cumulative anthracycline dose in a patient's lifetime, the greater the risk of developing cardiac toxicity. This table here depicts the cumulative dose of doxorubicin as a lifetime dose and associated risk with developing heart failure. So you can see at 300 milligram per meter squared lifetime dose of doxorubicin, the risk is 1.6%. Increasing that to 450 milligram per meter squared lifetime dose, this exponentially increases to 3.3%, and then further increases with 600 milligram per meter squared lifetime dose, all the way up to 8.7%. So very important as pharmacists that we're monitoring patients' cumulative anthracycline dose. And then generally we consider the lifetime limit of somewhere around 500 to 550 milligram per meter squared. It's kind of hitting an unacceptably high rate of heart failure. And exceeding this would need to be associated with very close monitoring of patients' cardiac function and a discussion of risks and benefits with the patient. Dexrazoxane has been an agent used for prevention of cardiotoxicity. Asco has guidelines on chemoprotectants and includes some guidance on the use of dexrazoxane for secondary prevention. Asco states to consider the use in patients with metastatic breast cancer who are responding to a doxorubicin-containing chemo and have received 300 milligram per meter squared lifetime dose by IV bolus administration, which is the most common way to administer anthracycline-containing regimens in breast cancer. Dexrazoxane is not recommended in the adjuvant setting, and dosing is based on a ratio. So this is typically a 10-to-1 ratio of dexrazoxane to doxorubicin. Dexrazoxane should be administered 15 to 30 minutes immediately prior to doxorubicin. And then when looking at other anthracyclines, it's noted that a dose ratio of the 10-to-1 may be reasonable with epirubicin, but the optimal dose for other anthracyclines has not been determined. So congratulations, we have wrapped up our discussion of early stage breast cancer, locally advanced breast cancers, as well as our discussion of cardiotoxicity. And so feel free to take this opportunity to stretch, get a snack, and then we will head into part 2 of our discussion where we'll focus on metastatic breast cancer and some additional supportive care topics. So welcome to part 2 of our discussion on breast cancer. We're going to be talking about the management of metastatic disease, including endocrine therapy options, chemotherapy, and targeted therapy options in this setting. We'll also talk about supportive care options for patients with bone metastasis, and we'll wrap up with some discussion on breast cancer survivorship. In discussing metastatic breast cancer treatment options, there are some key differences between the metastatic setting and what we've talked about in the early stage setting. The goals of therapy in the metastatic setting have shifted to palliative, where we're concerned with prolonging patient survival and improving their quality of life. Although metastatic breast cancer is rarely curable, many patients are living with this more like a chronic disease, so living many years with the disease and doing very well. Survival has improved dramatically with newer therapies in the past decade. It's important to understand the site of metastatic disease in order to understand our treatment options as well as understanding the disease course. Patients with bone mets tend to have more indolent disease and respond well to endocrine therapy for those patients that are hormone receptor positive. For those patients with visceral metastatic disease, so this would include such spread as to the liver, lung, and brain, especially those patients with symptomatic visceral disease, chemotherapy is generally indicated for a rapid response and to decrease their symptoms. For patients with brain mets, it's historically had minimal response to systemic therapies because few agents cross the blood-brain barrier. However, there are some very promising newer therapies that have shown activity in the brain, in particular in HER2-positive disease. It is a standard of care to biopsy recurrent disease whenever feasible, and this is because a number of studies have shown discordance between the receptor status of their primary biopsy and their recurrent disease. It's also recommended that patients undergo biomarker, that pathology be sent out for biomarker testing. For patients with all breast cancer subtypes, it should be tested for BRCA1/2 mutations, and consideration should be given for testing for NTRK fusions, MSI high or dMMR, as well as tumor mutational burden to determine whether immunotherapy options may be appropriate. For patients that are hormone receptor positive or HER2 negative, it's recommended to test for PIK3CA mutations to help drive therapeutic options. And then for patients that are triple negative, it's recommended to additionally test for PD-L1 expression. The next couple of slides will provide an overview of treatment options in the metastatic setting. You can see that we still consider pathologic features of the disease, such as hormone receptor status and HER2 status, just like we had discussed in the early stage setting. But in the metastatic setting, we also need to consider whether or not patients have extensive or symptomatic visceral involvement of their metastatic disease. In a patient that has extensive or symptomatic visceral involvement, examples being liver or lung mets, patients often need a rapid response to therapy in order to control their symptoms. Since you're not likely to get a rapid response to hormonal therapies, chemotherapy is the foundation for initial treatment in these patients with symptomatic disease. In patients that are also HER2 positive, anti-HER2 or HER2-directed therapy would be added to chemotherapy. For those patients that are HER2 negative, chemotherapy by itself, or with consideration for the addition of immunotherapy in patients that are PD-L1 positive, may be considered. For select patients that have a BRCA1/2 mutation, olaparib or talazoparib could be considered. This slide depicts the treatment options for patients that do not have extensive or symptomatic visceral involvement, and therefore don't necessarily need that rapid response that we would get from chemotherapy. We'll first focus on the left side of the algorithm with hormone receptor positive disease. And you'll notice here that endocrine therapy is included as a treatment option. For those patients that are also HER2 positive, HER2 targeted therapy may be added to endocrine therapy. Patients may also be considered for chemotherapy here, knowing that HER2 positive disease tends to be more aggressive. For patients that are hormone receptor positive and HER2 negative, the mainstay of treatment is endocrine therapy, with or without additional targeted therapies that will be discussed in upcoming slides. In the right side of the algorithm, we have patients that have hormone receptor negative disease. You'll notice here that chemotherapy is the mainstay of treatment. For patients that are also HER2 positive, a HER2 targeted agent would be added to chemotherapy. And then for those patients that are triple negative, chemotherapy alone or chemotherapy with the addition of immunotherapy may be considered for those patients that are PD-L1 positive. For patients with a germline BRCA1/2 mutation, olaparib or talazoparib are also treatment options. Patient DS is our first patient case in the metastatic setting. This patient is a 60-year-old postmenopausal female who presents with metastatic breast cancer. She has complaints of back pain, and bone metastases are confirmed via bone scan. Her pathology shows estrogen receptor 40% positive, PR 20% positive, and HER2 negative. Therefore, this patient has hormone receptor positive, HER2 negative disease. So audience response question. What treatment is most appropriate for DS's newly diagnosed metastatic disease? Remember, she's postmenopausal, estrogen receptor positive, progesterone receptor positive, HER2 negative. A, palbociclib plus letrozole. B, everolimus plus exemestane. C, gaserelin plus tamoxifen. Or D, capecitabine plus trastuzumab. The correct answer here is A, palbociclib plus letrozole. DS is hormone receptor positive and HER2 negative, and therefore endocrine therapy with or without targeted therapy is most appropriate. Here, letrozole, which is an AI, is appropriate for this patient because she's postmenopausal, and palbociclib, which is a CDK4/6 inhibitor, can be added to this therapy. Answer B, everolimus plus exemestane, is incorrect because this therapy would be considered in second or subsequent lines of therapy. C, gaserelin plus tamoxifen, is incorrect because this patient is postmenopausal and therefore ovarian suppression with gaserelin would not be necessary. And then D, capecitabine plus trastuzumab would not be appropriate because this regimen does not contain any endocrine therapy, and trastuzumab would not be necessary for DS because she is HER2 negative. And just to show where DS fits into our previous treatment algorithm, so she did complain of some back pain, but she had no extensive or symptomatic visceral involvement of her breast cancer. She was hormone receptor positive and HER2 negative. And again, this leads us to endocrine therapy plus or minus targeted therapy being the most appropriate option. DS is treated with palbociclib plus letrozole for about 15 months. Repeat CT scan at this time reveals new lung metastasis. DS is asymptomatic, and additional biomarker testing is negative for actionable mutations. Audience response question. What second-line treatment do you recommend for DS? Again, our postmenopausal patient with ER positive, PR positive, and HER2 negative disease. Is it A, abemaciclib plus anastrozole? B, everolimus plus exemestane? C, alpelisib plus fulvestrant? Or D, ribociclib plus tamoxifen? Answer B is the correct option, everolimus plus exemestane, which is a guideline recommended option for patients with second and subsequent lines of therapy. And this is based on the Bolero II trial in which patients had benefit following non-steroidal aromatase inhibitor therapy with either anastrozole or letrozole. Option A, abemaciclib plus anastrozole, is not correct because this patient previously received a CDK4/6 inhibitor in the frontline therapy, and at this time it's not appropriate to continue CDK4/6 inhibitor in subsequent lines of therapy. Answer C, alpelisib plus fulvestrant, is not correct because this patient did not have a PIK3CA mutation. And then D, ribociclib plus tamoxifen, is also not correct because this patient previously received a CDK4/6 inhibitor in the frontline setting and therefore would not receive a CDK4/6 inhibitor in subsequent lines of therapy at this time. Also, the combination of ribociclib and tamoxifen is not recommended due to increased risk of cardiac toxicity. There's a lot of important information on this slide, so we're going to spend a little bit of time here discussing endocrine therapy options for patients with hormone receptor positive, HER2 negative metastatic breast cancer. Options here are appropriate for both postmenopausal as well as premenopausal patients. However, premenopausal patients should also be receiving OAS in the form of either oophorectomy or with an LHRH agonist. Preferred endocrine therapy options in the frontline setting are listed on the left-hand side of this table. Options include a CDK4/6 inhibitor plus an AI, a CDK4/6 inhibitor plus fulvestrant, fulvestrant with or without a non-steroidal AI, such as an estradiol or letrozole. All three of these options that we just listed are considered to be Category 1 recommendations. Other options include a non-steroidal AI by itself, a SERM, which here would be either tamoxifen or teremorphine, or a steroidal AI with exemestane. In the second column in this table, we have preferred strategies in the second and subsequent lines of therapy. Most importantly, when we're considering second and subsequent lines of therapy, we need to consider what therapies patients received in previous lines, and we would want to choose options that did not overlap with what the patient received in the first line or previous lines of therapy. So options here in second and subsequent lines include a CDK4/6 inhibitor plus fulvestrant if a CDK4/6 inhibitor had not been previously used, alpelisib plus fulvestrant, which would be an option only for patients with a PIK3CA mutation. Both of these options are considered to be Category 1 recommendations. Other options here include everolimus plus endocrine therapy, and endocrine therapy options to be included with everolimus could be exemestane, fulvestrant, or tamoxifen. Another option is fulvestrant alone, or a non-steroidal AI, an estradiol or letrozole alone, a steroidal AI with exemestane, or finally a SERM, either tamoxifen or teremorphine. Asco has also put forth guidelines for the treatment of hormone receptor positive metastatic breast cancer. They state that patients whose tumors express any level of hormone receptor, so ER and/or PR, should be offered endocrine therapy. Treatment should be continued until disease progression. The use of concurrent chemotherapy and endocrine therapy is not recommended in this setting, just as it is not recommended in early stage breast cancer. Although it's important to note that even in the metastatic setting, these therapies can be used sequentially. Chemotherapy may be appropriate as first-line therapy for a select subset of patients with hormone receptor positive disease, and some of these considerations are listed here. Examples being immediately life-threatening disease, such as a symptomatic visceral involvement. Also, those patients with extremely low levels of estrogen, in which their tumors behave like hormone receptor negative disease. And also, chemotherapy may be a consideration for frontline for those patients that also have HER2 positive disease, in which this disease may be more aggressive as well, and patients may benefit from a course of chemotherapy. The addition of HER2 targeted therapy to first-line aromatase inhibitor may be offered to patients that don't have an indication for chemotherapy, and also those with significant comorbidities in which chemotherapy would affect quality of life. One of the greatest advances in the treatment of hormone receptor positive metastatic breast cancer is the targeted therapy class CDK4/6 inhibitors. It's known that CDK4/6 is involved in a mechanism of endocrine resistance, and the thought here is to target this known mechanism of endocrine resistance to try to improve response to endocrine therapy. CDK4/6 complexes with cyclin D1, which is elevated in patients with hormone receptor positive breast cancer. This complex of CDK4/6 and cyclin D1 leads to downstream signaling, which ultimately causes unregulated cell proliferation. CDK4/6 inhibitors block this complex and ultimately puts the brakes on the cell cycle. It does not cause cell apoptosis, just an arrest of cell proliferation. These agents are all approved for use in hormone receptor positive, HER2 negative metastatic breast cancer. Agents in this class include palbociclib, ribociclib, and abemaciclib. Guidelines state that these agents can really be used interchangeably. Any one of them can be used in combination with an AI or fulvestrant in the frontline or subsequent lines of therapy. These agents are generally well tolerated, but it's important to note that they can all cause a reversible neutropenia, which is the most common adverse effect with this class of drugs. Patients' complete blood count should be closely monitored for this adverse effect and adjusted appropriately according to the PI. We'll now discuss some of the important clinical trial data that led to the approval of these agents. Palbociclib was the first CDK4/6 inhibitor to be approved by the FDA in 2015. This was based on the results of the Paloma trials. All patients in these trials were hormone receptor positive and HER2 negative with advanced or metastatic breast cancer. Their first trial to be published was Paloma II. This was looking at palbociclib in combination with an AI letrozole versus placebo plus letrozole. This was strictly done in a postmenopausal patient population as first-line therapy. There was a remarkable improvement in progression-free survival, so nearly a 10-month improvement in survival in the palbociclib arm, with a hazard ratio of 0.58. The Paloma III trial was in a slightly different patient population and line of therapy. Paloma III looked at palbociclib in combination with fulvestrant versus placebo plus fulvestrant, and this was in a pre- and postmenopausal patient population. It's important to note in all of these trials with CDK4/6 inhibitors in premenopausal patients, these premenopausal patients also received an LHRH agonist to shut down ovarian estrogen production. So they received the LHRH agonist, their CDK4/6 inhibitor, and the endocrine backbone. Paloma III was conducted in second or subsequent lines of therapy following progression on prior endocrine therapy. Progression-free survival was significantly improved in the CDK4/6 inhibitor arm here as well, with a hazard ratio of 0.46. In Paloma III, overall survival was a secondary endpoint, and that, although numerically improved in the palbociclib arm, was not statistically significant. We'll briefly discuss some of the evidence to support the second CDK4/6 inhibitor approved by the FDA, ribociclib. This was based on the Mona Lisa trials. So again, all patients were hormone receptor positive and HER2 negative with advanced or metastatic breast cancer. We're going to walk through the Mona Lisa 2, 3, and 7 trials, and there are a lot of similarities to what we talked about with the Paloma 2 and 3 trials. Mona Lisa 2, like Paloma 2, was combining or looking at the combination of CDK4/6 inhibitor, in this case ribociclib plus letrozole, versus placebo plus letrozole in a postmenopausal patient population as first-line therapy. Progression-free survival was incredibly similar to what we saw with Paloma 2, with about a 10-month improvement in progression-free survival in the ribociclib arm, the hazard ratio of 0.568. Mona Lisa 3 was similar to Paloma 3, and then it was looking at the combination of CDK4/6 inhibitor, in this case ribociclib, plus fulvestrant, versus placebo plus fulvestrant. Mona Lisa 3 was strictly done in a postmenopausal patient population and could have been in the first or second lines of therapy. Progression-free survival was improved in the ribociclib arm at 20.5 months versus 12.8 months in the placebo arm, hazard ratio of 0.593. Median overall survival at 42 months was also statistically significantly improved with ribociclib with a hazard ratio of 0.72. Mona Lisa 7 was a trial that looked at ribociclib in combination with endocrine therapy. In this case, it was either tamoxifen or an AI versus placebo with the same endocrine therapy backbone. This patient population was strictly premenopausal as first-line therapy, endocrine therapy, but important to note that patients may have received one previous line of chemotherapy for advanced disease. Progression-free survival was also about a 10-month improvement in the ribociclib arm versus the endocrine therapy and placebo arm, with a hazard ratio of 0.55. Overall survival was also statistically significantly improved at 42 months, with about 70% in the ribociclib arm versus 46% in the placebo endocrine arm, hazard ratio of 0.71. Important to note, again, with the Mona Lisa trial being in a premenopausal patient population, these patients also would have received an LHRH agonist to shut down ovarian estrogen production, or would have undergone an oophorectomy. Ribociclib, again, is generally very well tolerated with reversible neutropenia as a well-known complication that needs to be monitored. It's important to note that ribociclib can also cause some EKG changes and that there's recommendations to monitor for this, as well as can cause hepatic impairment, and recommendations to monitor hepatic function are listed in the PI. Although MONALEESA 7 did look at the combination of tamoxifen and ribociclib, this combination is no longer recommended due to increased risk of EKG changes. We'll briefly walk through the Monarch trials, which led to the approval of abemaciclib. Similar here, all patients were hormone receptor positive and HER2 negative with advanced or metastatic breast cancer. We'll first discuss Monarch 1, which was unique compared to all of the other CDK4/6 inhibitor trials that we've talked about. This was an open-label phase 2 single-arm study looking at single-agent abemaciclib, so this was not with any endocrine therapy backbone. This patient population was both pre- and postmenopausal patients. They had progressed on or after prior endocrine therapies and had received 1 to 2 chemotherapy regimens in the metastatic setting. The patients had received a median of 3 lines of prior systemic therapy in the metastatic setting, and nearly all patients had visceral disease. Abemaciclib was studied here at a dose of 200 milligrams twice a day, which is higher than what is typically used in combination with endocrine therapy. The primary endpoint here was an overall response rate, and this was 19.7%. So based on this, abemaciclib did gain an FDA approval as a single agent in patients with a very refractory disease who had progressed through multiple lines of endocrine as well as chemotherapy. Monarch II was a phase 3 trial similar to what we've seen in both the MONALEESA and in the Paloma trials, in which patients were randomized to abemaciclib plus fulvestrant or fulvestrant and placebo. This was a pre- and postmenopausal patient population, and progression-free survival was significantly improved in the abemaciclib arm with a hazard ratio of 0.553. Median overall survival was also improved in the abemaciclib arm with about a 9-month improvement in overall survival, a hazard ratio of 0.76. And then Monarch III was a phase 3 trial randomizing patients to a non-steroidal AI, so either anastrozole or letrozole plus abemaciclib, versus the non-steroidal AI plus placebo in a postmenopausal patient population. Progression-free survival here was improved to about 14 months in the abemaciclib arm compared to the placebo arm with a hazard ratio of 0.54. Abemaciclib, similar to the other CDK4/6 inhibitors, is well tolerated with reversible neutropenia being a common complication, but is generally less significant than what is seen with palbociclib and ribociclib. Abemaciclib is also known to cause diarrhea, which can be worse in the initial month of therapy. Patients should also be monitored for LFT elevations. We'll move on to discuss some additional targeted therapies in the treatment of metastatic hormone receptor positive breast cancer. We'll start with a patient case, HZ. This is a 47-year-old postmenopausal female diagnosed with ER positive, PR negative, HER2 negative, stage 1A invasive ductal carcinoma 2 years ago. She was treated with breast conserving surgery followed by radiation and anastrozole. She presents to medical oncology for follow-up after 18 months on anastrozole with new complaints of bone and hip pain. She's now found to have stage 4 breast cancer with metastatic disease to the bone. Her rebiopsy is similar to the initial biopsy where she's ER positive, PR negative, HER2 negative. Biomarker testing shows that she has a PIK3CA mutation and is germline BRCA1/2 negative. Audience response question number 10. What is the most appropriate option to treat HZ's metastatic breast cancer? A. Alpelisib plus fulvestrant. B. Everolimus. C. Doxorubicin and cyclophosphamide or AC. Or D. Olaparib. The correct answer here is A. Alpelisib plus fulvestrant. This is based on the SOLAR-1 trial that led to the FDA approval of this combination in patients with PIK3CA mutated breast cancer like HZ who had progressed on or after prior endocrine therapy. Option B, everolimus, is incorrect. Although this agent is recommended in second or subsequent lines of therapy, it is recommended in combination with endocrine therapy. C, chemotherapy with doxorubicin and cyclophosphamide would not be the most appropriate option for this patient. She does not need symptomatic visceral disease and has not exhausted endocrine therapy options, and therefore chemotherapy would be reserved for later lines of therapy or should the patient develop symptomatic visceral disease requiring a rapid response to therapy. And D, olaparib would not be correct for this patient because she does not have germline BRCA1/2 mutated breast cancer. As we've discussed, everolimus is an option for patients in second or subsequent lines of therapy for hormone receptor positive metastatic breast cancer. This is based on the BOLERO-2 study, which looked at the combination of everolimus plus exemestane versus exemestane plus placebo. So these patients had an improvement in progression-free survival by about 4 months with the combination of exemestane plus everolimus. Response rates were also improved with the addition of everolimus. However, overall survival was not improved. This drug should be monitored, has some very specific toxicities. Patients can develop diarrhea and rash, but also need to monitor for stomatitis, hyperglycemia, dyslipidemia, and pneumonitis. There is data for the combination of everolimus with several different endocrine backgrounds, including tamoxifen, fulvestrant, exemestane, and there's also some data looking at the use of this agent with trastuzumab. Alpelisib is another targeted therapy which is added to our options for treating hormone receptor positive metastatic breast cancer. This first-in-class agent was approved by the FDA in 2019. It inhibits PI3K. The PI3K pathway is the most commonly mutated pathway associated with tumor progression in hormone receptor positive breast cancer. Approximately 40% of patients with hormone receptor positive HER2 negative advanced breast cancer will have a PIK3CA mutation. This agent is indicated in combination with fulvestrant for postmenopausal patients with hormone receptor positive HER2 negative PIK3CA mutated advanced or metastatic breast cancer. And this is following progression on or after endocrine-based regimens, so would not be recommended as first-line endocrine approach. The dose here is 300 milligrams PO once daily with food, and this agent has some unique toxicities, in particular hyperglycemia, which is well associated with alpelisib. It's also known to cause rash, diarrhea, nausea, and decreased appetite. Alpelisib's approval was based on the SOLAR-1 trial, which was a randomized double-blind phase 3 trial of over 500 patients. We were either postmenopausal women or men with hormone receptor positive HER2 negative advanced breast cancer. All patients had previously received endocrine therapy. Patients' tumor tissue was analyzed for a PIK3CA mutation, and they were put into either the mutated or non-mutated cohorts. Patients in these cohorts were randomized to alpelisib, 300 milligrams PO daily, in combination with fulvestrant at its FDA-approved dosing, every 28 days until disease progression, or placebo plus the same dose of fulvestrant every 28 days until disease progression. The primary endpoint was progression-free survival in the cohort with the PIK3CA mutation. At a median follow-up of 20 months, the progression-free survival in the cohort with the PIK3CA mutation was significantly improved with the addition of alpelisib at 11 months versus 5.7 months, a hazard ratio of 0.65. In the proof of concept cohort without the PIK3CA mutation, progression-free survival was 7.4 months for the combination of alpelisib plus fulvestrant versus 5.6 months for placebo plus fulvestrant, hazard ratio of 0.85. This shows that the activity of alpelisib is mainly limited to those patients with the PIK3CA mutation. Serious adverse effects were increased in the alpelisib arm. And as we mentioned before, hyperglycemia is an adverse effect that needs to be closely monitored. This was nearly 37% in those patients that received alpelisib plus fulvestrant versus 0.7% in fulvestrant alone. Alpelisib can cause severe hyperglycemia, including ketoacidosis. Patients should have fasting blood glucose and hemoglobin A1C monitored at initiation of treatment as well as periodically throughout treatment. And patients may need to initiate or optimize their anti-hyperglycemic medications. And there is the potential need for interruption, dose reduction, or discontinuation of alpelisib for this toxicity. This agent was also associated with an increased incidence of rash compared to those patients that received fulvestrant alone. Our next patient case, BZ, is a 50-year-old postmenopausal woman who presents with jaundice, dyspnea upon exertion, and fatigue. She's diagnosed with left breast cancer that has metastasized to the liver and lung. Pathology shows triple-negative disease, which is PD-L1 negative. She has a germline BRCA2 mutation. Audience response question number 11. What is the most appropriate treatment for BZ at this time? She's postmenopausal, it's triple-negative disease, that's germline BRCA2 mutation positive. A. Rucaparib, B. Talazoparib, C. Gemcitabine, or D. Doxorubicin. The correct answer here is B. Talazoparib. A PARP inhibitor with either talazoparib or olaparib would be an appropriate option for BZ based on her germline BRCA2 mutation. Option A, rucaparib, would be incorrect because this drug is currently not indicated for use in metastatic breast cancer. C and D, single-agent chemotherapy with gemcitabine or doxorubicin could be appropriate options for this patient following progression on a PARP inhibitor. Approximately 10% of patients with breast cancer will have a germline mutation in BRCA1 or BRCA2 genes. These are tumor suppressor genes which are involved in the maintenance of genomic integrity. PARP inhibitors prevent PARP-dependent DNA repair system, which ultimately results in double-strand DNA breaks. PARP inhibitors are options for patients with metastatic breast cancer and germline BRCA1/2 mutations. They're FDA approved for patients with HER2-negative disease. However, NCCN Guidelines suggest that they're an option regardless of HER2 status. These agents are approved as single-agent therapy with options for olaparib 300 mg PO twice daily and talazoparib 1 mg PO daily. I'd like to highlight the Umbraca Trial, which led to the approval of talazoparib. This was an open-label phase 3 trial of 431 patients with advanced breast cancer and a germline BRCA1 or 2 mutation. Patients were randomized 2-to-1 to talazoparib 1 mg PO daily versus physician's choice of single-agent chemotherapy with either capecitabine, gemcitabine, eribulin, or vinorelbine. Median progression-free survival was significantly improved in the talazoparib arm by 3 months, at 8.6 months versus 5.6 months with chemotherapy. Improved quality of life was also noted in the talazoparib arm. Overall survival was not significantly different between the two arms, but this analysis may have been confounded by subsequent lines of therapy. Hematologic grade 3 adverse effects were greater in the talazoparib arm. This was mainly anemia, and patients should be monitored closely for myelosuppression. We can see where a patient BZ's case fits into our initial treatment management strategies. Because BZ has a germline BRCA2 mutation, she's a candidate for olaparib or talazoparib. She has triple-negative disease, so she's also a candidate for chemotherapy, which in her case would be considered following any progression on a PARP inhibitor. Because BZ has triple-negative disease, she would not be a candidate for any endocrine therapy, as well as any HER2-targeted therapies. Olaparib or talazoparib are options for her based on her BRCA2 mutation. Platinum chemotherapy would also be an option for a patient with triple-negative BRCA1/2 mutation. However, there have been no head-to-head studies with a PARP inhibitor, so it's hard to determine which one is a more appropriate option. We'll now move into some discussion of chemotherapy for treating metastatic breast cancer. Chemotherapy can be considered for first-line treatment, particularly for patients with hormone receptor negative tumors and for those patients that have symptomatic visceral metastases. Combination versus sequential single-agent chemotherapy has been studied. There are higher response rates with combination chemotherapy. However, this has not typically led to any survival benefits. Guidelines generally recommend single-agent chemotherapy, but for patients who require a rapid response to therapy in order to control symptoms, they may have a benefit from combination chemotherapy despite additive toxicity. Chemotherapy is generally continued until progression or unacceptable toxicity. Most patients will require multiple lines of chemotherapy as palliation and generally progressively have shorter response time to each line of therapy. Preferred chemotherapy for metastatic breast cancer, according to NCCN guidelines, are listed here. On the left side of this slide, you can see the preferred single-agent chemotherapy with doxorubicin or liposomal doxorubicin, paclitaxel, capecitabine, gemcitabine, vinorelbine, or eribulin. Other options that are considered preferred include olaparib or talazoparib, as we previously discussed, for germline BRCA1/2 mutations, platinum chemotherapy with cisplatin or carboplatin for those patients that are triple negative and have a germline BRCA1/2 mutation. And then further options include combinations of immunotherapy and chemotherapy for patients with triple negative breast cancer who are PD-L1 positive. Options here include what's listed on the side with atezolizumab plus albumin-bound paclitaxel. And also what you can add to this option is a newly approved option for pembrolizumab in combination with chemotherapy. NCCN further breaks down their recommendations for chemotherapy into other recommended regimens and then regimens that are considered useful in certain circumstances. The list of other recommended regimens is included here. And then you'll see that under the useful in certain circumstances generally includes those combination chemotherapy that we know may be associated with improved response rates, but also have increased toxicities and have not shown a survival benefit. We're now going to take a look at some of the trials supporting the role of immunotherapy in addition to chemotherapy for patients with triple negative breast cancer that have PD-L1 positive disease. The first trial in this setting was the IMpassion130 trial, looking at the combination of atezolizumab plus nab-paclitaxel, or also known as albumin-bound paclitaxel. This was a randomized double-blind phase 3 trial of patients with metastatic or unresectable locally advanced triple-negative breast cancer. Patients had received no previous chemotherapy or targeted therapies for metastatic disease. These patients were randomized 1-to-1 to either the combination of atezolizumab plus nab-paclitaxel or placebo plus nab-paclitaxel. Primary endpoints were progression-free survival and overall survival in the intent to treat and the PD-L1 positive subgroup. First, looking at the primary endpoint of progression-free survival, you could see that in both the intent to treat population, which included both PD-L1 positive as well as PD-L1 negative patients, and the PD-L1 positive subgroup, both had statistically significant improvements in progression-free survival with atezolizumab. Looking at overall survival, this difference was not statistically different in the intent to treat population with a hazard ratio of 0.87. It was numerically greater in patients with PD-L1 positive disease, but because of the pre-specified hierarchical statistical design, it could not be formally tested in this subgroup. Progression-free survival was the same at 5.6 months in both the atezolizumab group and the placebo group, in the subgroup analysis of the PD-L1 negative population, really showing that the treatment effect was limited to these patients with PD-L1 positive disease. In this trial, PD-L1 positivity was defined as greater than or 1% staining on tumor-infiltrating immune cells. Based on the results of this trial, atezolizumab and nab-paclitaxel received accelerated approval from the FDA for patients with PD-L1 positive triple-negative breast cancer. I'd also like to mention that there was a subsequent trial, Impassion 131, evaluating atezolizumab plus paclitaxel versus placebo plus paclitaxel in the same patient population. This trial failed to meet its primary endpoint of progression-free survival in PD-L1 positive and PD-L1 negative patient populations. The interim overall survival analysis actually favored the placebo arm, which led to the FDA issuing a warning for providers not to use the combination of atezolizumab plus paclitaxel at this time. The second and more recent trial to support the use of immunotherapy for patients with triple-negative breast cancer was the Keynote 355 trial. This was a randomized double-blind phase 3 trial, patients with metastatic or locally recurrent unresectable triple-negative breast cancer. Similar to the Impassion 130 trial, these patients should have received no previous chemotherapy or targeted therapy for metastatic disease and had a good ECOG performance status of 0 to 1. Patients were randomized to receive either pembrolizumab plus chemotherapy, which could have been nab-paclitaxel, paclitaxel, or the combination of gemcitabine and carboplatin. Or they could have received placebo plus the same chemotherapy options. Median progression-free survival was statistically significantly improved with the combination of pembrolizumab and chemotherapy, but only for those patients that were deemed PD-L1 positive with a CPS score of greater than or equal to 10. The difference here was 9.7 months versus 5.6 months. There was no significant difference for patients that had a CPS of greater than or equal to 1. The overall survival analysis is immature at this point. This combination of pembrolizumab plus chemotherapy was granted accelerated approval based on the results of these studies, but will need confirmation of benefit. To provide a quick overview of the use of immunotherapy plus chemotherapy in metastatic breast cancer, the FDA has approved the combination of atezolizumab plus albumin-bound paclitaxel for first-line treatment of PD-L1 positive metastatic breast cancer. There is no survival benefit in the PD-L1 negative subgroup, and therefore it should not be used in PD-L1 negative disease. The PFS benefit is promising, but overall survival remains immature at this time, and the combination of atezolizumab and paclitaxel is not recommended based on the interim results of the Impassion 131. The combination of pembrolizumab plus chemotherapy, which here includes either nab-paclitaxel, paclitaxel, or the combination of gemcitabine and carboplatin, is also an option for the first-line treatment of PD-L1 positive metastatic triple-negative breast cancer. This benefit is limited to patients with a CPS score of greater than or equal to 10. It is important to note that a different PD-L1 assay was studied with each of these agents, atezolizumab and pembrolizumab, and therefore they are not interchangeable in this respect. Atezolizumab was studied with PD-L1 positivity on tumor-infiltrating immune cells, whereas pembrolizumab was studied with PD-L1 positivity defined as a combined positive score. Chemotherapy is generally continued until progression or unacceptable toxicity. At this time, another line of systemic therapy can be considered. Patients often require multiple different chemotherapy regimens during their course of their breast cancer treatment. Patients should be frequently reassessed for the value of ongoing therapy, including the risks and benefits of additional lines of systemic therapy, the patient's performance status, and the patient's preference for additional therapy. Sassachuzumab Govatikan is a newly approved option for the treatment of metastatic triple-negative breast cancer. This agent gained accelerated approval by the FDA in 2020. This drug is a first-in-class TROP2-directed antibody-drug conjugate that consists of a humanized antibody attached to SN38, the active metabolite of irinotecan, which is a topoisomerase I inhibitor. This drug is indicated for the treatment of patients with metastatic triple-negative breast cancer who have received at least 2 prior lines of therapy for metastatic disease. It's dosed at 10 milligrams per kilo IV on days 1 and 8 every 21 days until disease progression. Select toxicities are listed here, but are similar to those that you'd expect with irinotecan, including neutropenia, diarrhea, nausea, and vomiting. Because of the risk of anaphylactic reactions, patients should be premedicated with antipyretics, H1 and H2 blockers. Corticosteroids may be used for those patients who have had a prior infusion reaction. The use of Sassachuzumab Govatikan is supported by the Ascent Trial. This was a randomized phase 3 study of patients with advanced triple-negative breast cancer who had received at least 2 previous lines of treatment in the metastatic setting. Patients enrolled in this trial had received a median of 4 prior lines of therapy, so generally a fairly heavily pretreated patient population. Over 500 patients were randomized to either Sassachuzumab Govatikan or physician's choice of chemotherapy, which included single-agent eribulin, gemcitabine, vinorelbine, or capecitabine. Primary endpoint was progression-free survival in brain metastasis-negative patients. So in those patients without brain metastasis, which were 468 patients, the median progression-free survival was statistically significantly improved with Sassachuzumab at 5.6 months versus 1.7 months with physician's choice of chemotherapy. Median overall survival was also improved in patients at 12.1 months with Sassachuzumab versus 6.7 months in physician choice of chemotherapy. We'll move along in our discussion of metastatic breast cancer by looking at the patient case GS. This is a 62-year-old postmenopausal woman who presents with metastatic breast cancer to the bone. She has mild pain associated with this disease that's controlled with an NSAID. She was originally diagnosed 10 years ago as a stage 2B, hormone receptor negative, HER2 positive cancer. She was treated with lumpectomy, adjuvant TAC, which is docetaxel, doxorubicin, and cyclophosphamide for 6 cycles, followed by radiation and 1 year of trastuzumab. Biopsy of her recurrent disease is consistent with the original pathology of hormone receptor negative, HER2 positive. Audience response question number 12. Which of the following regimens is the most appropriate for GS at this time? A. Trastuzumab alone. B. Pertuzumab plus docetaxel. C. Trastuzumab plus lapatinib. D. Trastuzumab plus pertuzumab plus docetaxel. The correct answer here is D. Trastuzumab plus pertuzumab plus docetaxel, which is considered to be a preferred treatment approach for first-line HER2 positive metastatic breast cancer. Option A is incorrect because single-agent trastuzumab would not be recommended in this setting. B is incorrect because pertuzumab should not be used without trastuzumab. And C, trastuzumab and lapatinib would be a correct option for treating metastatic HER2 positive breast cancer, but is not considered to be a preferred regimen. We'll take a quick look at where GS fits into our treatment algorithm. This patient does not have extensive or symptomatic visceral involvement. She has hormone receptor negative and HER2 positive disease, so she should be treated with a combination of chemotherapy and HER2 targeted agents. We'll now move into a discussion of HER2 targeted therapies for metastatic breast cancer. This is an area of tremendous growth in the last year. Previously, there were 4 options listed here, and we now have 9 different agents that can be used in this setting. We have our monoclonal antibodies, several of which we've already talked about in the early stage setting, with trastuzumab, pertuzumab. We also have our combination of trastuzumab and pertuzumab with hyaluronidase for sub-Q administration, and then a new addition monoclonal antibody, margetuximab, for metastatic HER2-positive breast cancer. We also have antibody drug conjugates with ado-trastuzumab emtansine, which is a trastuzumab combined with a microtubule inhibitor. We have fam-trastuzumab deruxtecan, an antibody drug conjugate with a mechanism of trastuzumab plus a topoisomerase 1 inhibitor. And then we have our HER2 targeting tyrosine kinase inhibitors with lapatinib, neratinib, and tucatinib. I'd like to briefly discuss those patients that are HER2 positive and hormone receptor positive. For these patients, it can be acceptable to treat in different ways. One option is starting with chemotherapy and HER2 targeted therapy for a course of time, and then potentially switching these patients over to endocrine therapy with or without HER2-targeted therapy. Another option for these patients is endocrine therapy with or without HER2-targeted therapy. And I've listed those options as delineated by NCCN Guidelines. These are options for postmenopausal patients or premenopausal patients that are also receiving OAS. Options include an AI with or without trastuzumab, an AI with or without lapatinib, AI with or without lapatinib plus trastuzumab, fulvestrant with or without trastuzumab, and tamoxifen with or without trastuzumab. There are a number of chemotherapy and HER2-targeted therapy combinations that are recommended in metastatic breast cancer. NCCN Guidelines breaks those down into preferred regimens versus other recommended regimens. Preferred regimens include the combination of pertuzumab plus trastuzumab plus a taxane. Pertuzumab plus trastuzumab plus docetaxel is a Category 1 recommendation. Other recommended regimens are listed here. Options include our antibody-drug conjugates with ado-trastuzumab emtansine, which does have a Category 1 recommendation by NCCN, and also fam-trastuzumab deruxtecan, which would be recommended for patients that have received 2 or more lines of therapy in the metastatic setting. We also have various options for the combination of trastuzumab plus chemotherapy. Trastuzumab can really be combined with most any chemotherapies in the metastatic setting, except for anthracyclines due to unacceptably high rates of cardiotoxicity. Other options include trastuzumab plus lapatinib without any cytotoxic therapy, the combination of tucatinib plus trastuzumab plus capecitabine, which is a Category 1 recommendation and would be considered for patients that have received at least 1 prior line of therapy in the metastatic setting, and then neratinib plus capecitabine. NCCN's inclusion of docetaxel, trastuzumab, and pertuzumab as a preferred first-line treatment approach for metastatic HER2-positive breast cancer is based on the results of the Cleopatra trial, in which patients were randomized to standard of care docetaxel, trastuzumab plus placebo versus docetaxel, trastuzumab plus pertuzumab. There was a statistically significant improvement in progression-free survival and median overall survival with the addition of pertuzumab. There was an impressive 16-month improvement in median overall survival with the addition of pertuzumab for these patients. Overall, this regimen was well tolerated and similar adverse effects to what we'd expect with docetaxel plus trastuzumab. However, there was an increased risk of several side effects, including diarrhea in patients that received pertuzumab. The results of the Cleopatra trial support the use of a taxane plus pertuzumab and trastuzumab for first-line treatment of metastatic HER2-positive breast cancer for a patient such as GS. GS would require close monitoring for cardiotoxicity, as we previously discussed, and she would continue this regimen generally for 6 to 8 cycles, at which time, for patients that have had a good response, can drop the taxane and continue pertuzumab and trastuzumab until disease progression or intolerable toxicity. The antibody-drug conjugate fam-trastuzumab deruxtecan was approved in 2019. This is a HER2-directed antibody-drug conjugate consisting of a humanized HER2 antibody linked to a small molecule DXd, which is a topoisomerase I inhibitor. This drug is indicated for patients that have received at least 2 prior lines of anti-HER2 therapy in the metastatic setting. It's dosed 5.4 milligrams per kilo IV every 21 days until progression, and select toxicities are listed here, including myelosuppression, nausea and vomiting, fatigue, and important to note, interstitial lung disease, which was fatal in 2.2% of patients on clinical trial. This approval was based on the DESTINY-Breast01 trial. This was an open-label, single-group, phase 2 trial of 184 patients with HER2-positive, unresectable, or metastatic disease who had all received previous treatment with ado-trastuzumab emtansine. Part 1 of this trial was a PK and dose-finding study, and then Part 2 evaluated the efficacy and safety of this antibody-drug conjugate, which was given every 21 days until disease progression. Patients in this trial were heavily pretreated with a median of 6 prior treatments. The overall response rate was very impressive in a heavily pretreated population, at 61.4%. The median duration of the response was 20.8 months, and median progression-free survival was 19.4 months. Margetuximab is a newly approved HER2 monoclonal antibody. It has increased affinity for the CD16A 158 allele compared to trastuzumab. It's indicated in combination with chemotherapy for the treatment of metastatic HER2-positive breast cancer in patients who have received at least 2 prior anti-HER2 regimens, at least one of which was for metastatic disease. It's given as a 15 milligram per kilo IV infusion every 3 weeks. And select toxicities in combination with chemotherapy include fatigue, nausea, vomiting, diarrhea, infusion-related reaction, and left ventricular dysfunction. Margetuximab has been studied in the Sophia trial, which was an open-label phase 3 study of patients with HER2-positive metastatic breast cancer who had received previous HER2 targeting agents. All patients had previously received trastuzumab, and most patients had received pertuzumab and adatrastuzumab emtansine. Patients were randomized to margetuximab plus chemotherapy or trastuzumab plus chemotherapy. Median progression-free survival favored margetuximab plus chemotherapy at 5.8 months versus 4.9 months, with a hazard ratio of 0.76. Progression-free survival was more pronounced in patients with the CD16A genotypes containing 158F allele. The median progression-free survival here was 6.9 months versus 5.1 months, indicating really its niche population may be in these patients. Tucatinib is a newly approved TKI that inhibits both HER2 and HER3. It's indicated in combination with trastuzumab and capecitabine for metastatic HER2-positive breast cancer in patients that have received at least 1 line of prior anti-HER2 therapy in the metastatic setting. It's a PO medication that's given twice daily, and select toxicities are listed here. Notably, diarrhea is less than the other TKIs of neratinib and lapatinib because this agent does not inhibit HER1 or the EGFR receptor. It's recommended that patients have LFTs monitored at baseline and every 3 weeks during treatment due to hepatotoxicity. The combination of tucatinib, capecitabine, and trastuzumab was evaluated in the HER2 CLIMB trial, which was a double-blind phase 3 trial of patients with HER2-positive advanced breast cancer and patients that had previously been treated with trastuzumab, pertuzumab, and adatrastuzumab emtansine. Patients were randomized to the combination of tucatinib, capecitabine, and trastuzumab versus placebo, capecitabine, and trastuzumab. It's important to note that approximately 47% of patients had brain mets. Of these, 40% of patients had treated in stable brain mets, 37% had treated in progressing brain mets, and 22% had untreated brain mets, which is a patient population which is typically excluded from clinical trials. The primary endpoint was progression-free survival in the first 480 randomized patients. There was a statistically significant improvement for the addition of tucatinib in both median progression-free survival as well as median overall survival. I'd like to highlight the patient population with brain mets, which was 291 patients. Here, that hazard ratio was 0.48 in favor of the tucatinib group. And remember, this included patients with untreated brain mets. Diarrhea was the most common adverse effect, but this was mostly grade 1 or 2. The survival benefit here was seen in both the total population as well as all subgroups tested. The outcome here showed that this is an active combination in heavily pretreated patients, including those patients with brain metastases. Our last trial to highlight is the NALA trial, which looked at the combination of neratinib plus capecitabine. This was an open-label phase 3 study of patients with metastatic HER2-positive breast cancer who had received at least 2 lines of prior HER2-directed therapy for metastatic disease. Patients were randomized to neratinib plus capecitabine versus lapatinib plus capecitabine, and important to note that the capecitabine doses were different between the 2 arms. Neratinib plus capecitabine reduced the risk of disease progression and death by 24% compared to lapatinib plus capecitabine, which was a statistically significant difference. Median overall survival was not statistically significantly different between these 2 arms. Important to remember that neratinib causes a significant amount of diarrhea, as we previously discussed in the extended adjuvant setting. Also important to note is that while we have all of these important additions to HER2-targeted therapies, what remains to be seen is how to appropriately sequence these agents, and that will be the subject of future clinical trials. We'll now wrap up with some discussion of supportive care strategies for patients with bone metastases and some survivorship discussion. Patient FR is a 37-year-old premenopausal woman with newly diagnosed bone mets. She has controlled back pain. Her disease is found to be ER/PR positive, HER2 positive, and she remains premenopausal at this time. Plan is to start chemotherapy plus HER2 targeted therapies with docetaxel, trastuzumab, and pertuzumab. Audience response question number 13. In addition to chemotherapy, which of the following would be a most appropriate regimen to prevent skeletal-related events, or SREs? Is it A, denosumab 60 mg sub-Q every 6 months, B, pamidronate 90 mg IV every 6 months, C, zoledronic acid 4 mg IV every 12 weeks, D, denosumab 120 mg sub-Q every 12 weeks? The correct answer here is C, zoledronic acid 4 mg IV every 12 weeks, which is a recommended dose and schedule by NCCN and Asco guidelines. Option A is incorrect because at this dose and schedule of denosumab would be indicated for patients with osteopenia or osteoporosis. B is incorrect because pamidronate is recommended to be given every 3 to 4 weeks and would not be recommended every 6 months. And D, denosumab 120 mg sub-Q every 12 weeks is not a recommended frequency for dosing denosumab at this time. Most patients who develop metastatic breast cancer will have a high likelihood of developing bone mets. The term skeletal-related event, or SRE, is a composite endpoint of clinically important events that can lead to substantial morbidity for patients. Most clinical trials define SREs as a combination of pathologic fractures, spinal cord compression or collapse, radiation or surgery to the bone, and occasionally include hypercalcemia. Asco guidelines for the use of bone-modifying agents include appropriate options as pamidronate 90 mg every 3 to 4 weeks, zoledronic acid 4 mg every 12 weeks or every 3 to 4 weeks, and denosumab 120 mg sub-Q every 4 weeks. Guidelines recommend that bone-modifying agents are not used alone for bone pain, that serum creatinine should be monitored prior to each bisphosphonate dose, and that all patients should have dental exam and preventive dentistry done before bone-modifying agents to prevent osteonecrosis of the jaw. Let's take a quick look at the clinical trials that evaluated the use of IV bisphosphonates for the reduction of skeletal-related events in metastatic breast cancer. Both pamidronate and zoledronic acid significantly reduced the incidence of skeletal-related events compared to placebo. In the only trial that compared two IV bisphosphonates, zoledronic acid and pamidronate, there was no significant difference between the incidence of skeletal-related events with these two agents. The use of denosumab versus zoledronic acid was compared for patients with bone mets from breast cancer. The median time to first skeletal-related event was statistically significantly improved with denosumab and actually met superiority criteria for this endpoint. The risk of multiple skeletal-related events was also statistically significantly improved for denosumab compared to zoledronic acid. Both time to disease progression and overall survival were not statistically significantly different between these two groups. There was a combined analysis of 3 phase 3 trials looking at denosumab versus zoledronic acid for the prevention of SRE. This included patients with breast cancer, among other cancers. Denosumab was superior to zoledronic acid in delaying time to first on-study SRE by 8.21 months. However, it's important to note that both Asco and NCCN guidelines list both denosumab and zoledronic acid as options for treating patients with brain mets. In looking at select adverse effects, denosumab had a higher incidence of hypocalcemia and hypophosphatemia compared to zoledronic acid. The OPTIMIZE-2 trial looked at prolonging the schedule of zoledronic acid in patients with metastatic breast cancer. randomized patients to zoledronic acid every 4 weeks for a year, compared to zoledronic acid every 12 weeks for 1 year. The every 12-week regimen was found to be non-inferior to the every 4-week regimen in terms of the proportion of patients that developed a skeletal-related event. Nccn Guidelines prefer the 12-week schedule based on the results of this trial and the CALGB 70604 trial, which is referenced in the prostate cancer module. We'll now briefly cover some highlights of breast cancer survivorship. There are a number of topics within breast cancer survivorship that should be mentioned, including both physical effects, the small risk of secondary cancers from the therapies that the patient may receive, as well as psychosocial aspects. Physical effects are numerous and listed here, including pain, neuropathy, fatigue, insomnia, lymphedema, among others. Hot flashes are a common adverse effect experienced by the majority of breast cancer survivors as a result of therapies, both chemotherapy and endocrine therapies. Chemotherapy and tamoxifen can cause more frequent and severe hot flashes than patients would experience with natural menopause. This can result in a decreased quality of life and may affect patients' adherence to endocrine therapy. Options for the management of hot flashes in patients with breast cancer include non-pharmacologic options listed here, including avoidance of hot flash triggers, wearing loose clothing, acupuncture. Non-hormonal pharmacologic options are listed here with SSRIs, SNRIs, gabapentin and pregabalin, or clonidine for refractory cases. There are options with herbal supplements. However, it's important to note that these may not be appropriate for patients with hormone receptor-positive disease, as they often contain phytoestrogens, which are controversial in this patient population. It's important to mention SSRI and SNRI effects on CYP2D6. Tamoxifen requires CYP2D6 to be converted to its active compound, endoxifen. There are a number of moderate and strong inhibitors of 2D6 that should be avoided in combination with tamoxifen. NCCN notes that sertraline, citalopram, escitalopram, and venlafaxine are appropriate options when used in combination with tamoxifen. Cancer treatment-induced bone loss is an important long-term complication. This can be a result of many therapies, in particular endocrine therapies such as AIs, in which bone loss is generally more rapid and severe than a natural aging process. To treat this complication, bisphosphonates and denosumab are the most well-studied agents. Agents associated with bone loss include chemotherapy, ovarian failure, LHRH agonists, tamoxifen, and aromatase inhibitors. Patient AH is a 50-year-old postmenopausal female receiving adjuvant letrozole for 5 years to treat stage 1A ER-positive, PR-positive, HER2-negative breast cancer. Her baseline DEXA scan reveals a T-score of negative 2.7. She is taking calcium 1,500 milligrams divided BID and vitamin D3 800 international units PO daily. Our last audience response question: in addition to encouraging physical activity and continued calcium and vitamin D supplementation, which of the following is the most appropriate for AH based on her DEXA result? A, denosumab every 6 months, B, observation, C, increased calcium and vitamin D supplementation, or D, zoledronic acid every 4 weeks. A, denosumab every 6 months is recommended based on this patient's T-score of less than -2. B, observation is incorrect because this patient is recommended for pharmacologic therapy. C, increasing calcium and vitamin D is not recommended because this patient is already on adequate supplementation. And D, zoledronic acid every 4 weeks is not recommended because this is the dosing recommended for bone mets. Physical activity and adequate calcium and vitamin D should be recommended for all patients. Subsequent recommendations are based on T-score, with repeat DEXA scans being done every 2 years. For a T-score of less than -1, consideration should be given to checking vitamin D levels. For a T-score between -1.5 and -2, there should be a consideration for pharmacologic therapy, and those with a T-score of less than -2 or based on FRAX score, a strong recommendation for pharmacologic therapy. This concludes the presentation. Thank you very much for participating.